Okay. All right. Today we're going to be talking about pediatric oncology, and I love giving this lecture because this is where I get to share my passion for nursing with you. Pediatric oncology is the reason I am a nurse. To those of you who don't know me very well, it's a pretty well-known fact that I hated nursing school every minute of every day, and I'm not just being funny, I really mean it. And I've always been a pretty happy person except for those 2 years. And the worst were clinicals. I would go to clinicals and I would think, this is not what I want to do with my life, and it just made it that much harder. Can anyone relate? Yeah, okay. So the good news is I graduated and I found out that nursing is nothing like nursing school. And no one told me that. And so I'm telling you, and it wouldn't be true if, I wouldn't be here if it wasn't true. So I'm just happy to share that good news with you. And the reason that I'm still here is because of those kids I took care of early in my career. I did a pediatric internship, a residency program when I graduated, and spent a month on each of the different pediatric units, and ended up on a very large general pediatric unit, which is where we had our oncology patients. And I fell in love with nursing because of those kids. And I fell in love with oncology, and I ended up getting my master's in oncology, and I loved graduate school. So there's some more good news for you. Loved every minute of it. So anyway, I'm going to start by showing you a video that has nothing to do with cancer, but it's just a great message. Let's see. No. Where'd it go? Let's just do this. This is for my clinical group. Can you all see that? one time when I showed that, the whole class shouted, "Yes!" Yes. I want you to remember that from today. It's such an important message, and one thing that I love about pediatric oncology is that pediatric oncology nurses are really good at that. We don't just show up, we are in 100%, and part of it is because our patients are so amazing. They keep us extremely humble, and I love that. They are so amazing, and one thing that we get a lot is that, oh, it must take a special person to do that, and I hate when people say that to me, because compared to our patients, you know, we just feel this big. We get to go home after 12 hours. Those families don't. And so there's this need to give 110% every day that you're there because you do it for them, yet at the same time you're just so humbled, and I love that balance. But one thing I love about pediatric oncology is that when we show up, we are there to show those kids how to live to the fullest, and it's so nice that we have all these YouTube videos now where you can see us dancing with those kids, and it's just a lot different from what you see on the St. Jude commercials. Usually pediatric oncology units are actually pretty happy places. We have a lot of fun, and those kids are really good at practical jokes. I've had a lot of practical jokes played on me, and just lots of happy memories. But our culture is to come in and just do what Johnny did, and I've seen lots of different things. But in pediatric oncology, when I worked at the National Cancer Institute, our kids who had solid tumors would come in for 9 months at a time, and they never got to go home. Every now and then they would maybe be well enough to go out on a day pass to go see DC. But because of that, when they were young, they had parents, but a lot of times our teenagers would be dropped off, and then their parents would go back home to be with their other kids. So those teenagers especially, they didn't always have parents with them. And so on Saturday nights, we would always bring in a potluck dinner, and we would just have a big party and bring all those kids in, and they loved Saturday night parties. We had a lot of fun. Another thing that's really common in our culture is when a patient is dying, we go in on our days off and spend those last days with them. And it's not because we're supposed to, it's because there's no place we'd rather be, and that's just such a privilege to work with these kids. But just a couple examples of what we do. I'm going to tell you a story about a little boy that I took care of a long time ago, and his name was Benjamin, and he was 8 or 9 years old, and I took care of him. And the interesting thing is, I can't remember if he had a Ewing sarcoma or Burkitt's lymphoma, and those two cancers are nothing the same. But it used to bother me that I couldn't remember what kind of cancer he had. But then one day it occurred to me, I think it's really cool that I can't remember because his cancer didn't define him. He was just Benjamin. But Benjamin was those little boys. I loved him, and he loved me. And when he was on the unit, it was just a given that I would take care of him. And so one night I showed up. I was working 11 to 7, and the nurse was giving me a report, and she said, "Benjamin's here. They got some really bad news today. His cancer's back with a vengeance, and they're trying to figure out what to do with him." And she said, "You're going to have him tonight, but you can't go in the room because he's working on a surprise for you." So I said, "Okay." Well, I went and saw my other patients first, and his door was plastered with signs. There was a sign that said, "No nurses named Jennifer allowed." There was one with a picture of me with a big red circle and the red line through it. And it was just fun. I would knock on the door. I'm like, "Benjamin, I'm coming in." And he's like, "No." And then I'm like, "It's Dr. Greenberg. I'm coming in." And he's like, "No, I know it's you." So this went on about 2 o'clock, and he had a lot going on. He had T-pan and lipids going, lots of blood products. He was really sick. He had a lot going on. So I kept having to send other nurses to go in and take down the blood and hang the platelets. And so anyway, it's like 2 o'clock. He finally lets me in. And so I walk in the room, and Benjamin is standing at the end of the bed, and he's just like bouncing up and down like this with his hands behind his back. And he is covered with neon paint. And there is neon paint everywhere. And so I walked in and I said, "Benjamin, it's about time you let me in. What have you been up to?" And he is just bouncing up like this, and he's got this grin on his face from ear to ear, and he says, "Jennifer, I don't know if you heard, but my cancer's back, and I'm not going to be around for much longer." And he's bouncing up and down, and he's got this big grin on his face. And it hit me, like a hockey puck in the chest the way he said it. And it was just so incongruent with, what he looked like. And it was a little bit too much for his mom, and she retreated to the back corner of the room, and I so badly wanted to go after her, but I couldn't because Benjamin had a lot to say. And so he's bouncing up and down. He says, "Jennifer, I love you, and I know you love me. And I wanted to make sure you never forget me. So I had this kit, and I could only make one, and out of all the people in the world, I wanted you to have it." And then he gives me this. And I love this hand, and what I love about it, he spelled my name wrong. And there's so little neon paint compared to what was on him and in the room. But I bring this hand to lecture. I've been bringing it to lecture with me for years. And the reason I bring this, and I'm going to pass it around, just be careful with it. The IT people broke it one time when they were switching up my computer. But the reason I bring that hand is to remind you that when I'm talking about these different cancers, I'm not talking about tumors, I'm talking about people. People who are near and dear to my heart. And today, about 45 kids are going to be diagnosed with cancer, and their lives are going to be turned upside down. And it's just an important piece to remember that, there's such a human element, and people, I'll leave it at that. But let me tell you what I said to Benjamin. What? Okay, so I said, "Benjamin, this is amazing." I said, "This is the most amazing gift anyone's ever given me, and I will cherish it forever." And I said, "I'm so glad you know that I love you, but I don't think you have any idea how much. Whatever it is you think you love, I love you. Just multiply it by a gazillion, and you'll be pretty close." And he giggled. And I said, "About your cancer," I said, "I want you to know your cancer every day that you're the boss. Cancer is not the boss of you, you're in charge. Can you do that for me and have a talk with that cancer every day?" And he said, "Yeah, I will." And then I said, "Another thing about your cancer is that if it weren't for your cancer, I never would have met you. And my world is just so much better and brighter because you're in it. And that's true for all the doctors and nurses who get to take care of you. And it would be impossible to ever forget you. But now that I have this hand, it'll be so much easier to tell people about you and how amazing you are. And I promise, Benjamin, you will never be forgotten." And then I gave him a hug, and to keep myself from bursting into tears, I said, "Let's clean up this mess." And so we cleaned up that mess. And he went home later that day, and he died 3 days later. And I didn't ever get to see him again except at his funeral, which I wasn't expecting. It went really, really fast. But there are several reasons I tell that story. It's not a very exciting story, but there are several reasons I tell that story. And the first reason is I think it illustrates probably what made me go from hating nursing school to loving nursing. There are all these incredible moments out there waiting for you. You just have to get past senior one first, and then get past NCLEX, and, a couple other milestones too. But it's so worth it. It is so, so worth it. And again, it just illustrates that it's not the St. Jude commercials. There's just so much more to it. There's an element of fun. There's an element of depth. This is really, really cool. But you're going to have these really tender moments, right, that aren't exciting, and you don't really feel the need to tell people about them, but they make you want to go back to work the next day, and they help you realize that what we do is really, really important. The other reason I tell this story is as a promise to an old friend that he would not be forgotten. And now that I've told that story, when I get home tonight, I can write a letter to his mom and just let him know that 25 years later, her sweet Benjamin is still very much remembered and very loved, and he's still making a difference, even though his life was cut way too short. And to me, it will take 5 minutes to do that, but to that mom, she's probably the most important person in this story. She is still suffering, and I know that as a nurse and as a professor, that's a gift that I can give her that other people can't. And that's what's so neat about working with these families. You get to work with them in a way that is different from anybody else. And you get to work with these families at their very worst, and they stay with you. They stay with you forever. And that's what forethought is all about. So that's just an important message I want to pass on to you, that forethought, just thinking, how can I make a difference? I can tell the story, and that's great for you guys. But really, it's kind of pointless if I don't take advantage of that opportunity to let her mom know that he's still very much remembered and loved. So that's what forethought is all about. And it's so important. Let's talk about cancer. I used to be an oncology educator at the University of North Carolina, and my job was to go all over the campus and teach people about cancer, and it was such a cool job, and most people look at me like I'm crazy, but I had so much fun with that job. But one day I was eating M&Ms in my office, and I thought, those look like cells. I don't have a place to hook this. Let's see. Let's try that. So anyway, when I teach people about cancer, the first thing I teach them is that in order for cancer to occur, a normal healthy cell has to mutate at least 2 times. Okay? I'm backing up. When I was in grad school in 1990, the current statistic is that 1 in 3 people alive at that time would get cancer. When I was updating my statistics just 15 years later, so it's still been a while, that statistic is closer to 1 in 2, especially for men. Men have close to a 1 in 2 chance of getting cancer. Women, it's still a little more, closer to 1 to 3. But overall, it's just amazing that in such a short period of time, our odds of getting cancer have increased. And I don't say that to freak you out, because there is a happy side to that statistic, in that we are diagnosing people earlier, and just because more people are getting it doesn't mean that more people are dying. We're actually getting much better at catching it early and intervening, and our treatment options are getting a lot more targeted, so it's not the same diagnosis that it used to be. And for men, even though that's now more like 1 in 2, one reason for that, A, we're living longer, and B, prostate cancer. And we know how to treat prostate cancer, especially if we catch it early. So that's the glass half full aspect of that. But for the next 30 minutes or so, I'm going to be talking about basic cancer concepts that aren't necessarily pediatric related, and the reason I do that is because we are all going to be afflicted by cancer at some point, whether it's as a neighbor, a friend, a family member, a nurse. And from what I understand in the program, they may talk about different adult cancers, but they don't really give you a basic understanding of cancer and treatment. So just don't feel the need to take notes, just sit back and kind of take this part in, okay? So you can open up your regular M&Ms, okay? And you can even eat them now, okay? So, you can come down and get some M&Ms if you don't have any yet. But if you open these up, one of each. But for now, just open up your regular M&Ms, okay? Okay, so before I talk about cancer, I'm going to talk about regular solid properties first. So if you look at these M&Ms, there are different colors, but they all pretty much look the same. The main difference is the color. And so think of this, so the red ones are your red blood cells, your yellow ones may be your osteocytes, your orange ones, your melanocytes, your blue ones, this can be your eye cells, and you put them all together and you get this beautiful body, right? But our cells pretty much have the same characteristics on the outside, but they all have different functions, and they're identified pretty easily under a microscope. But you put them together, you get this beautiful body. One reason that they form this beautiful body is the cell membrane. So that candy coating is really, really important when we're talking about cellular biology on so many different levels. But what happens if I were to take this bag of M&Ms and leave them in my car? What would happen to them? They would still hold their shape. They might be soft, but they're still going to be M&Ms. They're not going to mold into one big M&M, are they? Okay. The reason for that is that membrane. All right. What happens if I take a bag of peanut clusters and stick it in my car in a hot Texas day? It is just going to melt and take on whatever shape it wants, right? And the reason for that is cancer cells don't have that cell membrane in the same level of integrity that regular cells do. So that's really important. We kind of take that for granted. The M on your M&M is really, really important. That's what identifies your M&M as yours. Okay? And these regular M&Ms are pretty flat, so most of them will have a nice and pretty M on them, although a lot of mine don't. I don't know how yours are. But for the most part, those represent your HLA typing. And so when we do transplants, we look to make sure that we're transplanting M&Ms into a body made out of M&Ms. So if I were to take, I have Skittles somewhere here. Anyway, these are peanut M&Ms, but let's pretend these are Skittles. And they're in here. What happens if let's say I want to do a kidney transplant, all right? Let's do liver. So we're going to take this liver out, and we're going to put in a new liver made out of Skittles. What's going to happen? You're going to have rejection. And what happens in rejection? Yeah, your immune system is going to attack this. Because you know what? Mine have an M. These belong to Mary. And you know what? These Skittles belong to Sam. Your immune system is trained to get rid of anything that doesn't have an M on it. And they're like, they don't belong here. So your body's going to attack those Skittles. And they're going to reject that new liver. Okay? Bone marrow transplant, it's different. Okay? Do you know what happens with a bone marrow transplant? I didn't know until I got out of school. But essentially, with a solid organ, you can just take that old diseased organ out, except the kidneys. We leave those in. But how do we get rid of the icky diseased bone marrow? We give toxic, lethal doses of chemo. All right? If you have a diseased bone marrow, you've got to get rid of every single cancer cell in there. The only way to do that is to completely obliterate it. And you do that through chemo, and you can do total body irradiation, which is horrible. And with total body irradiation, you put them in this room, and they have to get into all these different funky positions so that you can get exposure to all the different bones, okay? So that you can obliterate all that bone marrow. So with a bone marrow transplant, we're going to get rid of essentially your immune system. Your immune system is trained to get rid of things that's not an M. So what happens when we infuse new bone marrow with Skittles? What's going to happen? Are we going to have rejection? We're not going to have rejection. Basically, you've wiped out your immune system that is trained to get rid of the M's, and you're infusing a new immune system that's trained to get rid of anything that doesn't have an S on it, right? So you've got the Skittles that are now attacking anything with the M on them. So that's how a bone marrow transplant is different from a solid organ transplant, okay? And it's all about your immune system attacking what doesn't belong, okay? How do you get the new bone marrow in? It's through a peripheral infusion. Okay, so kind of like a blood transfusion. It usually goes into a central line, though, not a peripheral line. But essentially, these Skittles are going into a peripheral vein, and they have to migrate and find their way to the bone marrow where they set up shop and start replicating and producing more. Okay, so even though we're infusing a new immune system, we still give immunosuppressants to tone down that response so that you don't get graft versus host quite as extreme. Now, you want to have a little bit of graft versus host because there's a protective mechanism. If you have a little bit of graft versus host, the chances of remission the chances of the cancer coming back are actually reduced. So, anyway, any questions about that? Okay. So that's what the M is about. Had a question earlier about transplants. When you get blood transfusions, every time you transfuse someone, those blood transfusions, unless they're leukocyte poor or irradiated, you've got antigens in that blood product. And so what happens when you do give a blood transfusion, those antigens stick to the surfaces of these cells. Okay? If you have someone who you know is going to get a bone marrow transplant, you're not just looking at the M, which is your HLA typing, you're looking for the presence of those surface antigens. So every time you expose someone to blood products, you're exposing them to surface antigens, which increases the chance that they're going to reject. You can still, and you know, in oncology, we do irradiate those, but not always. But for the most part, we have to be careful. If we know someone's on a transplant list, and you see this especially with kidney transplants, you do not want to transfuse them because it exposes them to antigens that are going to increase the chance of rejection. So we're looking not just at the M or your HLA typing, we're looking for those surface antigens. Okay. We are learning so much more about the surface of these cells, and it's just so exciting. And this is how we're making major progress with cancer treatments and targeted therapies. So, I'll talk about that in just a minute. The most important part of the cell is the inside, the DNA, the chocolate part. And what's so cool about that is that your DNA programs when cells are going to die, naturally, the process of apoptosis. A red blood cell, what's the lifespan of a red blood cell? 120 days. That's all programmed into your DNA. It's your platelets. It's going to tell this platelet to die in 10 to 12 days, right? It tells your body when you're going to have a growth spurt. It's going to tell you when your hair is going to turn gray. All of that is wired into your DNA, okay? It's very, very important. So when that DNA gets altered, that's when you run the risk of having the process where these cells don't know how to do their job well and they don't know when to die. And you've got proto-oncogenes, you've got oncogenes, you've got tumor suppressor genes, you've got all these different genes that we now know so much more about because of the genomic projects that are going on that help us identify how to treat these, okay? Yeah. So I said earlier that cancer, in order for cancer to occur, cells need to mutate at least 2 times. So we need to open up your peanut M&Ms. Okay. And you can eat these. Just you can eat them. Just don't leave them all over the floor and step on them. Because one of these days I'm going to get in trouble. All right. Now, I love this picture. I don't know how well you can see it. But I used this packet of M&Ms in post-conference, and there's this great mutated cell right there. But essentially, your immune system is trained to go through and survey the scene and get rid of anything that doesn't belong. And these are an example of the first mutation. And you can see they look pretty much the same, right? They're the same colors, they're round, they don't look that different. If you have a really strong immune system, they're going to come by and say, you know, that's a funky shape that's kind of round. I'm going to get rid of it. And it's not just abnormal cells, but of course it's all those things you get exposed to, viruses, bacteria. Your body's trained to get rid of anything that doesn't have an M. Invariably, you're going to have in this peanut M&M packet, the M's often are going to look like an N because it's really harder to stamp an M on a round surface as opposed to a flat surface. Mine actually look pretty good. But anyway, your body's going to get rid of things that don't belong. All right. The main difference between the plain M&Ms and these is the inside, the DNA, right? That's the main difference. You now have this little peanut thing that looks a little bit different. And that's going to alter when the cell is going to die. So if you have this cell that's got some changes in the genetic material inside the cell, if it mutates again, you can develop cancer. But at the same time, you can hang out with these cells with the primary mutation for a long time and they never change. So I have some examples up here of primary mutations. Anything with dysplasia or hyperplasia. Hyperplasia is when you've got extra cells, but they're still fairly normal. Dysplasia is when you've got additional cells, but they look different under a microscope, so they are mutated. Okay. The main change is that you've got some sort of alteration in the gene. Now, we know so much more about certain genes like the BRCA1 and 2 genes, we know that if you have that gene, essentially you were born with peanut M&Ms, not plain M&Ms. So you are one step ahead of the game. You just need one more mutation. That doesn't mean you're going to. It just means that it's a whole lot easier for someone with that gene to get cancer because you already have your primary mutation that you're born with. Okay? We're learning more and more about these genes all the time. Lynch syndrome. There's a genetic link between uterine cancer and colon cancer, and we now can look for that gene. So when someone has colon cancer or uterine cancer, we will test for that gene because we can alert that next generation that they're at a higher risk. So that's what these primary mutations are all about. One thing that we see a lot, chronic esophagitis. What that does is it causes constant turnover of cell growth. Anytime you've got an alteration in that cell growth, you run the risk of things going haywire during mitosis, right? When you've got that cell division. Anytime you have rapid growth, whether it's a growth spurt, you can have things going haywire. Every time you have an injury, you can go haywire. In kids who have fractures in a growth plate, that's always dangerous because not only is a growth plate a place of rapid growth, but if you have a fracture, your body goes into overdrive trying to repair that. And that's a common place where osteosarcoma occurs. And it usually occurs after a growth spurt or after a fracture. Okay? So we always freak out when we see fractures and growth plates. That's why. Okay? Anytime you have a rapid acceleration, you run the increased risk. A good example of this, if you have that chronic esophagitis and you don't do anything about it, the more your body is in a rapid state of repair, the more likely these are to mutate again because they just aren't following that normal pattern. Okay? Any questions about that? Exposure to chemo and radiation. Okay? One of my pet peeves is when nurses, older nurses, they come in to do the portable x-ray and they refuse to put an apron saying, oh, I'm not having kids anymore, I'm past that. But here's the deal. Every time you get exposed to that radiation, and as a nurse you get exposed to this over and over and over, it's causing changes in your ovaries. Even though you don't need your eggs for reproduction anymore, you can still run the risk of developing cancer when you're exposed over time. The radioactive events that happen in the environment, there was an event in Utah that happened in the 50s, those usually take a couple decades for cancer to occur. All right, so all these mutations that take place and all the things that cause cancer, this is why not everyone who smokes ends up with lung cancer. If you have a really strong immune system and you're getting rid of these mutated cells, I was teaching a 7-year-old with M&Ms one day, and he was saying, is this why George Burns never got cancer? I don't know if you guys know who he is, but he was a comedian who just smoked constantly, and he never got sick. He lived to be, I don't know, do you know how old he was? Yeah, he was old. But I thought that's pretty smart for a 7-year-old. Yeah, so obviously. So I show you this so that you can teach your family members and your friends about cancer, because usually when you get out the M&Ms, it usually perks people up. Let's see. Yeah, I think cervical dysplasia is really common. If you've got cervical dysplasia and you just don't do anything about it, get exposed to the HPV virus, and boom, there you have your second mutation. Okay, so just being aware of any genetic link, that's why this is so important, so that you can take those preventive measures. Okay? If you have dysplastic nevi, those have an increased risk of becoming cancerous. Basically, the more you know about the genetic makeup, the more you can take precautions. Let's go back to this. Let's see. What's that? Did he really? Wow.
Smoke cigars every day.
Yeah. Okay. Causes of mutations. students usually freak out when they see coffee. When I was in grad school, coffee was really pretty well linked to bladder cancer. But interestingly enough, as our consumption of coffee has increased, the incidence of bladder cancer has not increased. So coffee is one of those things that kind of goes back and forth between being good and bad for you. And people freak out, students freak out when they see that. But I just leave it up there just to make sure you're awake. Let's see. Alkylating agents. There are certain chemo treatments, Cytoxan, Aracy. Alkylating agents are a common drug classification that most people who have cancer get. They have a tendency to cause changes in the DNA as well. So you probably learned about this in pharm. When you give chemo, they work in different ways, but generally traditional chemo doesn't discriminate between cancer cells and regular cells. It'll kill anything that's fast growing. Your anti-metabolite drugs, they're going to attack cells that are in the S phase. You've got alkylating agents that attack cells regardless of what stage they're in. Your vinca alkaloids, they're going to attack cells that are in the M stages of cell division. So that's why they're given in combination. If you give those drugs in combination, you're going to hit all the different cells that are in different phases of cell division. This is why fast-growing cells are really susceptible to chemo, because the more rapid turnover, the more likely you're going to catch those cells in different stages of division. Okay. The problem with this, though, is that it attacks all the cells. So you have a lot of side effects that affect the whole body. When we're moving forward with cancer therapy, it's just so exciting because we're learning more about those cell proteins, those surface proteins. And that's where most of the advances are taking place. When I was in grad school, monoclonal antibodies were just a concept. And so I have this little mouse. So let's say we inject this mouse with tumors. What's the mouse going to do in response? The mouse is going to make antibodies specific to that tumor. Okay? And we're learning so much more about how the body responds to it. The immune system is very complex. But essentially what you can do, you inject these into the mouse, the mouse will create antibodies, you pull those antibodies out, and they will attack the tumor specifically. Okay, and that's what monoclonal antibodies are. We were doing lots of different therapies like this at the National Cancer Institute back in the 90s, and it's interesting. At the time, we didn't realize how effective these monoclonal antibodies were going to be. But essentially, you have specific antigens that are on the cell surface that cause the cancer to proliferate. Breast cancer is a really good example. Not all breast cancers are alike, and we used to just treat them all the same. Now we're treating them very specific. So if a tumor, let's just say this is a breast tumor. Okay, let's say, and I used to have this big block of Swiss cheese, but I don't today. But essentially, if a tumor is estrogen dependent, think of it like a big block of Swiss cheese. You have all these little holes, and those are your receptor sites for estrogen. When estrogen gets into those little holes, it causes that tumor to proliferate. Tamoxifen looks like estrogen, so if you can get estrogen into those little receptor sites before the actual estrogen, it will block the estrogen from getting into those little holes, and then the tumor can't proliferate. You don't want to do that for tumors that aren't necessarily estrogen dependent, although they do with some. Okay? But that's just an example of a targeted therapy. If it's HER2 positive, that's another marker on the tumor. We can block that little receptor, that antigen receptor, with Herceptin, and there's another drug, I can't remember the name of it, but essentially it prevents, it'll bind to that antigen site, and that'll keep it from proliferating. But you have to have a way for that drug to get inside the cell to kill the DNA so that the cell dies. And so there's a whole lot more to it. You can't just create an antibody specific to that antigen. You have to find a way to get it in. So, there's a whole lot to this technology. Some of these cancer cells, they thrive on the concept of angiogenesis, which is the ability to develop new blood vessels that feed the tumor. And so one of those examples is neuroblastoma. Has anyone seen neuroblastoma? Neuroblastoma, and actually if you have your notes, your study notes, I'll just talk about neuroblastoma now and we'll get that out of the way. But neuroblastoma is it's a tumor in kids, usually occurs in preschoolers and toddlers. And it can occur anywhere along the sympathetic nerve chain, but most of the time it's going to originate on the adrenal glands, okay? I want you to think of neuroblastoma as like ovarian cancer. It's very sneaky. So if it starts on the adrenal glands back here, it's going to grow to the path of least resistance. Which way is the path of least resistance? Into the abdomen, right? It's not going to grow out here. It's going to grow into all that free space in the abdomen. There's a lot of free space in toddlers' bellies, right? And so it can grow out of control for a long time before it's detected. And it's one of those nasty tumors that wraps itself around the organs. It wraps itself around the aorta. It can strangulate blood vessels. But at the same time, it is going to develop its own vasculature on the outside of this tumor. Okay? Now, what's really interesting about this, let's say this is a neuroblastoma tumor, and they're never this pretty. Usually they're wrapped around your organs. They're very difficult to resect. But you're going to have all these blood vessels on the surface. If you were to cut this tumor in half and look at it, what would the inside look like? It's going to be necrotic. That vasculature that grows on the outside of the tumor, it's feeding the outside of the tumor, which causes it to grow outward. But without your little cell membrane, think of your peanut clusters, it's just going to crowd that center. And without the cell membrane, you're not going to have the vasculature feeding the inside of the tumor. So if you were to cut this in half, that inside is going to be necrotic. All right, it needs that blood supply. And so with angiogenesis, your body responds by developing this new vasculature to feed the tumor. And so there are drugs that block that process. Classification of drugs. Now, how these kids present, usually they come in with this huge abdomen, right? And the skin gets really stretched, and it looks like blue cheese. You can see all those veins that are growing on the outside of the tumor. And the skin is stretched, and it's tight, and it's very pale, okay? So that's just an example of how tumors have a way of creating environments that make them thrive. Okay. It's gradual, and they have big bellies. Well, how often does a 2-year-old, 3-year-old go to the doctor? Once a year. Usually it's detected, and this is like an NCLEX point. You'll see it all of a sudden they've outgrown their diapers, right? And all of a sudden they're really, really tight. But again, it can occur anywhere. The other thing that we look for with, classic NCLEX thing you need to know, if a kiddo has raccoon eyes, basically that occurs when you've got neuroblastoma that's in the spine and it's causing compression, which causes the blood vessels to pop. I've got pictures that I'll show you later. But again, how we treat these kids depends on, or not just kids, but cancer in general. We treat them based on these different properties on the cell membrane. Okay, so let's say we have Hodgkin's. Okay, and Hodgkin's often will present as a mediastinal mass right here. Okay, good news is we know how to treat Hodgkin's. We're like, oh, it's only Hodgkin's, very easy to treat. Usually what we'll do is we'll give them chemo, but we'll also give them radiation to the site of their mediastinal mass. Okay, so with radiation, it's very different from chemo. Chemo goes throughout the body. With radiation, what you do is you attack just those cells where the tumor is. It's very targeted, very site-specific. But you also want to irradiate a margin of healthy tissue just outside of that tumor, because if you have tumor cells infiltrating outside the primary, you want to make sure you get that tissue. Now what happens with radiation is that little beam is going to get inside the DNA, and it's going to destroy it, and it's going to die. Okay? What happens with that little margin of healthy tissue, it may not kill the cells, but it'll turn it into a peanut M&M. It'll cause changes. Okay? So it's not uncommon for years later to develop a secondary malignancy at the site of radiation. That's a secondary malignancy. It's different from metastasis. And how you can tell, let's say you have an osteosarcoma. Commonplace osteosarcoma metastasizes to is the lungs. If you have lung lesions and you biopsy those, you're going to find cells that are osteocytes. Okay? And that's how you know that it's actually a metastasis and not another primary tumor or a secondary tumor. Whereas if you were to biopsy this tissue where you have a secondary malignancy, you can tell that it originates from that healthy tissue, right? So, again, if you have metastasis in the lung and you biopsy it and it has osteocytes, then you know it's metastasis because it traveled off and originated from there. And that's why it's really important to understand how cancer evolves. It originates from a normal healthy cell, okay? And how you treat them really depends on that, okay? Sometimes you have tumors that are a tumor of unknown origin. It'll be all over. And basically, this process has been going on so long that as it mutates, everything just gets all mixed together. And those tumors are really hard to treat because you don't know which drugs to use if you don't know where it originated from. The last thing I want to talk about as far as tumors, I've had this for like 20 years. So this is Capricorn. What happens if I put this in the microwave? This is actually made to go in the microwave. Okay, right? But I haven't done it. As old as it is, I doubt anything would happen to it. But are you familiar with the term differentiation? You see it in the charts a lot. If you have a patient with cancer, the chart will often say it's a poorly differentiated tumor or a well-differentiated tumor, and it's really confusing. So hopefully this little analogy will work. So I want you to think of these little yellow kernels as your regular M&Ms, right? So when you put this in the microwave, you're going to have some of these kernels turn into popcorn, right? And are they going to look anything like the cell it originated from? No. And then you have some of these kernels that are maybe going to turn a little bit darker, and they'll be, maybe brown, but they still kind of look like the cell it originated from. The more a cancer cell looks like the cell it originated from, the more likely it's going to respond predictably to chemo or to treatment. Okay? Chemo works on the cell cycle. Okay? Those cells that are now popped, they don't look anything like the cell it originated from. They're not going to act like normal cells. They're going to be doing their thing. So the more different these cancer cells look from the cell that originated, the harder it is to treat them, the less likely they're going to respond appropriately to chemo. Okay? So this is why early detection is really, really important. If you wait until they're off to the popcorn stage, they're not going to respond as well. Now what's confusing about this, a tumor that's well differentiated, those are the brown kernels that look like the original. A well differentiated tumor has a good prognosis. A poorly differentiated tumor has a poor prognosis. It's kind of the opposite of what you would think it would be. But that's how I think of differentiation. Okay. Any questions about that? See, grad school is so much more fun. It's just fun to learn about the stuff on the cellular level. All right, I've talked about a lot of these. One thing that comes up, you get, as a nurse, you get asked lots of questions. One thing I get asked a lot is that, my aunt has colon cancer and they found, positive nodes. What does that mean? The way I explain this, if you think of like breast cancer, so you've got this breast tumor. It's usually in the upper outer quadrant, right? Your body's going to respond by the nodes closest to it, grabbing those cells that are abnormal, right? It's constantly surveying the scene. It's going to grab those cells that are abnormal. And this happens every day. It's happening in all of us right now. Your body pulls those abnormal cells, they get in the lymph nodes, and they process, chew them up, and spit them out. Okay? It's happening constantly. In the case of a fast-growing tumor, and actually breast tumors are very slow-growing, but for the most part, if you've got that sentinel node pulling those abnormal tumors and they can't process them fast enough, it can clog that node. And it's when that happens, if you're not processing them and getting rid of them, they become positive. And once those nodes are positive, it has the propensity to travel off and metastasize. Okay? So that's when, if you can just explain that, you know, when you have a cold, you can feel those nodes, right? It's just your body responding to that infection, processing and chewing it, spitting it out. With cancer cells, basically they get clogged, right? So that's how you can explain that node concept, that it just means that you have an increased risk of it metastasizing if those nodes are positive. Okay. All right. We're doing a lot with vaccines. It's so exciting. You can take tumor out of someone, make a vaccine, and put it back in. We're doing that actually at Medical City. It's pretty cool. Okay. How do you get those vaccines into those tumor-specific vaccines to the tumor? You essentially attach them to a virus. And that serves as your vector to get it to the tumor, because your body is trained to attack those. Sorry. Okay. I put this picture here just to show you that you've got your immune system is everywhere, right? And it's just trained to pull things and process them right there. Okay. I like this slide because they look like M&Ms. But essentially you can see here your blood capillaries, these are your tissue cells. Essentially you can see how easy it is if you've got tumor cells, how easy it is for them to find their way into a blood vessel from the lymph node. Okay, so most of your breast tumors are going to be in your upper outer quadrant. And you can see if it gets into a node, the main places it metastasizes to is the brain, bone, liver, and lung, which when you look at this, all of those are pretty much in close proximity. You can see how easy it is for them to travel to those areas. Okay. All right. Moving on to leukemia. Leukemia is just fascinating. Most people know that leukemia is basically cancer of the white blood cells, and the definition I hear all the time, which drives me crazy, is that it crowds out the other cells. This is really important that you understand the difference. It doesn't just crowd it out, it prevents cells from forming. Your bone marrow is trained to, a hematopoietic stem cell has propensity to become a red cell, white cell, or platelet, depending on what's going on in your body. If you're bleeding out, your body is going to shoot out more red blood cells, okay? If you need more platelets, your body's going to respond by taking those hematopoietic stem cells and, creating the cells that you need, okay? So what happens in leukemia, essentially, you've got these normal cells, and something will cause this process to take off, and instead of creating regular NMs, you've got all these immature, sorry, I need another arm. But essentially, you've got your body shooting out these immature M&Ms, okay? Now what happens is if all those cells are becoming immature white blood cells, your body's not going to produce your other cells, your red cells and your platelets, okay? Now, if you think about this, what's your lifespan of a white blood cell? It's very short, like 12 hours to 2 days. It's very, very short, okay? Red cells, long, okay? So it's going to take a while for those to die off. Platelets, 10 to 12 days. So if you can understand that if all those hematopoietic stem cells are becoming immature white blood cells, it's going to take a while for those red cells to be affected because they're going to hang around for a while, whereas your platelets, they're going to die off sooner than your red blood cells. You had a question?
Just to clarify, those are smaller,
These
plain M&Ms?
these are smaller plain M&Ms. They're minis. So I want you to think of leukemia as immature white blood cells. So what's really important to understand is that these aren't just crowding out the bone marrow and the blood. It's creating red cells and platelets from being developed. Okay, so I want you to expand your concept of leukemia. It's not that the white cells are crowding others out. It's preventing them from being created. Okay? Oops. Okay. So essentially you've got your hematopoietic stem cell and you're creating all these little baby M&Ms. Okay? Leukemia refers to many, many different diseases and they respond differently. And just breaking it down, usually the first letter is going to be for acute or chronic. Okay, so that's easy. Hairy cell leukemia gets its name from its appearance, and then you've got mixed lineage right here. The L at the end is for leukemia, and this is the most important, this middle initial. Okay, so you've got acute and chronic, you've got leukemia at the end, and the middle initial is what's most important. And essentially, if you've got your stem cell, it has the propensity to become a platelet or a red blood cell. But then if you look at this, look at all the different white cells it can become. And this is what your differential is. Okay, you know, when you look at your differential, you've got your white blood count, and then your differential tells you what percentage of those white blood cells are these. Okay? So essentially, you can have the mutation anywhere along the cell line here. Okay? So you can have lymphocytic leukemia, and then you can have B-cell leukemia, which has a great prognosis, or you can have T-cell leukemia. Okay? Or you can have myelocytic leukemia, which is any of these cells along this line. You can also have, people will use the term monocytic and myelocytic leukemia, similar, but basically that name comes from whether that mutation occurs on this cell line or this cell line, and it matters because how we treat them is different. Prognosis is different. Even with ALL, B cell is much easier to treat than T cell. Okay, so it's important to know where that mutation is. Okay. All right, so this is what a normal CBC is going to look like. This is your stem cell, and then you're going to create these nice, balanced levels of red cells, white cells, and platelets. In leukemia, at any given time, you have a finite number of these stem cells that have the potential to become one of these other cells. And this is what a leukemic CBC is going to look like. All right? So you've got all these white blood cells, but they're immature. You're going to see your red cells over time come down, but your platelets are going to drop faster because their lifespan is a lot shorter. Okay? I like this picture because they look like M&Ms, peanut M&Ms. So basically you can see the inside looks a lot different. And what happens in the bone marrow, these changes usually occur in the bone marrow, and then your bone marrow pops them out into the periphery. Okay? All right, this is a hairy cell leukemia. Hence the name hairy cell leukemia. Kids don't get hairy cell leukemia. That's a grown-up leukemia. Okay, so let's talk about acute leukemia. So again, leukemia, lots of different diseases. All right, they're all treated differently. With acute leukemia, if they're very rapid, and if you don't treat them, the patient will die very quickly. So early detection is really important. Okay. If you don't treat leukemia, what is it that they're going to die from? Infection, right? Essentially, you've got this high white count, but they're not effective at fighting infection. Here's my analogy, and I hope no one's offended by this analogy, but you think of the fighter cells, your white cells as fighter cells. So if you can think of a normal white count, let's say it's 10,000, right? So if you have 10,000 troops and you send them off to, where do you want to send them? Syria. This semester we'll send them to Syria. Okay? So we send 10,000 troops to Syria. Okay? If we bring 9,000 of those back and replace them with her, 9,000 of her, you're still going to have 10,000 soldiers. But is she going to be as effective? No. That's leukemia. Okay? All right? So, again, same number of soldiers, they're just not going to be as effective. With chronic leukemia, you can live with chronic leukemia for a really, really long time. So my analogy for that is that you have 10,000 troops, you bring 9,000 of them back, and you replace them with these guys. Again, they're very experienced, they're very smart, but probably not as adept at fighting as the baby. They're going to be more effective, and they're going to survive a little bit longer in the battlefield than the infant, because they can feed themselves. The infant, she can't. Okay, so that's leukemia. Any questions about that? Yes. Chronic leukemia. Now, adults can get acute leukemia. Kids can get chronic leukemia. When I talk about the baby and these old men, it's not who gets it, it's what the cells function is like. Okay? Any questions on that? Okay. So with chronic leukemia, we don't see as much in pediatrics, but we do see it. And essentially, you can live with that for a long, long time. Okay. So what do they look like? If you can understand the patho, all of the symptoms make sense, right? So because you're not replenishing your supply of your platelets, you're going to have petechiae, all the signs that you're going to have with low plates, petechiae and bruising. Okay, these kids come in covered with bruises, all right? Fever can go on for a long time, and I've got a great history to read to you, but essentially, the typical scenario is these kids go to the doctor, they have fever, right? Usually a virus, they send them home. If it comes back, they'll give them antibiotics, and this can go on for a long time. But normally it's hard to find the source of infection. They just have fever because you have this inflammatory type response going on. You have your body producing all these new cells, okay? If you have a bone marrow that's packed with all these blasts, it's going to cause bone pain, right? And what's really important to know, this is an NCLEX point, is that if you have a kid who's on treatment and they start complaining of bone pain, you don't assume it's from the treatment. You should immediately start thinking, do we need to look to see if that cancer is coming back? Bone pain is not good. It's a red flag, so we always worry about bone pain. And then anorexia is really common just because they've got this process going on. And then abdominal pain, a lot of times these kids will get hepatosplenomegaly, so their abdomens are often large. Okay. These are the different places that leukemia can infiltrate. They can get into the lymph nodes. Basically, this process happens in the bone marrow. Those blasts will pop out on the periphery, and then your body responds by your spleen and liver trying to process them. It can also infiltrate the testicles, so we always look for testicular masses. It can get into the CSF, which is why we do spinal taps, okay? And then skin infiltrates, and I've got some pictures to show you. This is what a packed bone marrow looks like, okay? So you can see all of this purple stuff is leukemia. You can see your platelets. You've got a few platelets in here. But if you can think about, that's what a packed bone marrow looks like. There's no space in between. It's like that peanut cluster, right? There's no cells bouncing off each other nicely as it's flowing through the blood. It's just packed, and it hurts. Okay. What causes it in kids, we really don't know. We do know that leukemia is a very common secondary malignancy. We see that a lot. We'll treat someone with a solid tumor, and then years later, it'll come back with, they'll have leukemia. And it's essentially when you treat these kids with chemo, it's going to cause changes in the DNA, and then something will trigger it to become cancerous. So just, keep in mind, every time you give someone an alkylating agent, it puts them at risk for leukemia. Essentially, we don't know what causes it in kids. There's a lot of theory that the power lines was causing it, but there's no evidence to support that. We do know that kids with Downs have an increased risk, usually AML, and there are certain chromosomal abnormalities that we know puts them at a higher risk, but for the most part, we don't know. So these are all the places it can occur, and when you think about how we treat it and what we look for in assessment, this is why. Okay, this is what they look like when they come in. I don't know if you can see this very well, but if you haven't seen petechiae, this is what it looks like. That happens when your platelets are low, and they come in with this massive bruising. And when they come to the Hemont clinic, you think, how? How did they miss this? Like, how can they look this bad? Why didn't somebody do something earlier? How many kids do pediatricians see in the doctor's office with fever? Every day, all day, every day, okay? That's what they see. How many pediatricians see a kid with leukemia in their career? Not many. They may see one or two in their career. It's not common. When they come to us in the Hemont clinic and we have all the pieces of the puzzle, you're like, oh my gosh, it makes perfect sense. But it follows this very ambiguous pattern. You've got fever, all kids get fever, right? You're not going to do a CBC on every kid who has a fever, all right? But that fever is happening when you've got this process taking place, but you still have your supply of red blood cells and platelets. That's, okay? This happens when those platelets start dying off. Okay, this is what I call a skin infiltrate. This obviously is an old person, but here's what's more common in kids, and we call these blueberry muffin spots. Okay, this is what they look like. We see this in congenital leukemia. We had a kid in clinical several years ago that was born with a white count of over 1 million. And if you look at if you haven't seen that on a CBC, you're like, what? Like, even just when you think how high your white count needs to show up for 1 million, it's pretty impressive. But this is what a skin infiltrate looks like. We call them blueberry muffin spots. Okay? All right, so hepatosplenomegaly, this is what it looks like. This is what they look like in real life. So their abdomens are often enlarged. Okay? So what do? The first thing we'll do is a CBC, and that will show usually a high white count, but not always. It's the differential that matters the most. So again, if you think about your my analogy with the babies, you can have 100,000 troops over there. If they're all those little babies, it's not going to do any good. Okay, it's not unusual for you to have a normal white count, but it's leukemia because it's the percentage of blasts that are within that differential. So you don't always have a super high white count. All right. Here's what it looks like in real life, and I know it's hard to see this. That's why I made this little column on the right. Here, white count 95,000. There's certain things we look at for prognosis, and I want you to know what they are. If you have the higher the white count, the poorer the prognosis. Okay. If your white count's above 50,000, not good. Okay, so this is pretty far along. Your hemoglobin is down to 5.2. What does that tell you about this particular cancer? What this is telling you is that this process has been going on for a long time because it takes a while for those red blood cells to die off. Okay, so it's pretty advanced. Your platelets are down to 15. Here's your differential. Your SAGs are your fighter cells, right? Okay, you have none of those. So you had 10,000 troops, you brought them home, all of them home and replaced them with the babies. And you've got 80% of your differential is abnormal cells. And then down here is where it says they're identified as blasts. So this is what leukemia looks like on a CBC. You cannot diagnose leukemia without a bone marrow biopsy. So this lab value gives us a high index of suspicion for leukemia, but you can't confirm the diagnosis without a bone marrow biopsy. So typical scenario, this is what you see when you draw CBC, then you bring them in. And what you're going to do, physical exam, looking for it in the testes, you're going to look at the spleen and the liver, good inspection of the skin, and then you're going to do a spinal tap to see if you have cancer cells in the CSF, and you're going to do a bone marrow biopsy. If you have cells in the CSF at diagnosis, that puts you high risk. If your white count is above 50,000, that's high risk. Okay. All right. And then we're going to do some other, we're going to look for tumor markers. This is an example of some cytogenic testing. And this is where we look for chromosome abnormalities. And this is really, really important with kids because there are certain cell mutations that we know put them in a high risk or low risk category. All right. So this is just a pretty picture of the Philadelphia chromosome. And what happens here, you've got genetic material coming off chromosome 22 that ends up on 9. And then you've got genetic material from chromosome 9 that ends up in 22. So that's what we call a translocation. All right. And that's going to guide our treatment. There are certain translocations with kids, like 411 translocation, high risk, not good. But anyway, I don't want you to be obsessed with that. Just know that translocations generally are not good. Okay. What is good, you've got 23 pairs of chromosomes. One thing we look for is hyperdiploid. If you have more than 23 pairs of chromosomes, that's actually a good prognosis factor. Okay. So it's just an important piece. We're not just looking at the CBC. We're looking at properties within that cell and within the DNA that guides how we treat them. It's just so exciting, all the advances that we've made. Okay, so here's the good news. Pediatric, do anyone know the cure rate for pediatric leukemia? It's pretty good. Depending if it's a pre-B, it's over 90%. That's pretty good. We've made a lot of progress. Adult leukemia, generally a poorer prognosis. All right. This is Aubrey. I met her when I was running a marathon, and she was pregnant with her at the time. Really, really neat girl. She's got a great story. She and I are about the same age. She's born in the 60s and was diagnosed, I think in 69 when she was like 4 or 5. And back then, she didn't really have a chance. We did not know how to treat it. Okay, but her parents, they took her to Memorial Sloan Kettering in New York. And she was started on a clinical trial, and she was in that first group of people on that clinical trial where we figured out how to treat it. Okay. What she had going for her is she had a really good prognostic file, and these I want you to know. I want you to know good prognostic factors versus bad. So if you're diagnosed with leukemia between the ages of 2 and 9, that's good. If you're diagnosed as an infant, that's bad. If you're diagnosed as an infant, that automatically puts you in the high-risk category. If you're above 9, also much more difficult to treat. So the first thing we look at is the age. Okay, so this is good. Her white count was less than 50,000. With induction therapy, and we treat this in stages, so when they're first diagnosed, we give them high doses of chemotherapy. That's what we call induction therapy. You expect them to go into remission with that first round of chemo, and since these are all fast-growing cells, they respond well to chemotherapy. If you don't go into induction with that first round of chemo, that's called refractory chemo, or refractory leukemia, and then you get bumped up to a higher protocol. Okay, but again, we look at all these prognostic factors and determine, do we have to treat you as high risk, or are we okay treating with the lower doses? Because the more aggressively you treat these kids, the more side effects you're going to have, and then it increases their risk for other cancers later. Okay, every time you irradiate a growing brain, it causes potential damage. If you irradiate the CSF, if you don't have to, you're causing cellular changes, and you're turning regular M&Ms into peanut M&Ms. So you don't want to treat them more aggressively than you have to. We look for something we call calopositive. That's just a characteristic within the cancer cell. and then hyperdiploid if they have more than 50 sets of chromosomes. Okay? So, here's her story. Her parents never told her she had cancer, which is not uncommon. That doesn't happen today. But back then, there was this big stigma. They would call it the big C instead of cancer. And so anyway, she was treated as a kid. And then when she was in college, she went to college in New York City, and she was a runner. So she was running all around New York City. She ran by Memorial Sloan Kettering, and she said, oh, that's where I went when I was a kid. And then it's Memorial Sloan Kettering Cancer Center, and she's like, but I didn't have cancer. So she called her parents. She's like, I was jogging through the city, and she said, what was wrong with me when I was a kid? And that's when she found out she was a cancer survivor. Had no idea. So kind of an interesting story. But this is her when she was little. Her chance was minimal. The only way to treat kids back then was symptom management. We gave them lots of blood transfusions. Okay. And then you can see we've made such great progress. So she's very fortunate. And again, now she's a mom. This is Hannah. Unfortunately, she's a family friend who had high-risk leukemia. She had actually T-cell leukemia, which is harder to treat. She was diagnosed at the age of 1, which puts her in a high-risk category. She had initial high white count. She also had blasts in her CSF at diagnosis. She had some really characteristically bad gene translocations. And then tumor lysis syndrome, which I'll talk about in a minute. She went into tumor lysis. Again, she had all these poor prognostic factors, and she actually died from complications from a bone marrow transplant. But these are important things for you to know, so there'll probably be test questions on that. Okay. All right. They're treated in 3 phases. Induction is where we give them that hardcore chemo, and then they go on chemo for about 4 years. We give them intrathecal chemo whether or not they have blasts in the CSF, just because it's a high risk that it's going to cross into the CSF. So we treat them prophylactically with intrathecal chemo. So these kids will get a spinal tap about every 3 to 4 weeks. We draw CSF off, and then we inject chemo of an equal amount. Okay, these kids go through a lot, but they go through this for about 4 years. And then if they do well, often we'll do a stem cell transplant. Okay, if they do have blasts in the CSF, and that's what CNS involvement means, we do give them radiation, but we don't do that unless we have to. But generally, chemo doesn't like to cross the blood-brain barrier, which is why we have to do the intrathecal chemo. Okay? All right, I'm going to talk about tumor lysis, and then we can take a break. All right, do you all know about tumor lysis? No? Okay. Well, you need to know it. All right. Essentially, if you've got a white count of 100,000, right, you've got all these little baby M&Ms, when you give them chemo, good news is that they respond. But what happens when you blast them with chemo? They're going to break open or lyse. Okay, so I want you to think of it as like chocolate milk. If we have all of these and they break open, you're going to have blood that's just full of chocolate milk. Okay, what's inside the cell that we worry about? Potassium, uric acid, and phosphorus are the main things. Okay, it's life-threatening. If you have a patient, whether they have leukemia or another tumor, if they have baseline renal failure, you need to worry about tumor lysis. If they have a high white count or if they have a very fast-growing tumor, you need to worry about tumor lysis. Okay, but essentially what happens is you can get full-blown renal failure, and you can also have life-threatening electrolyte imbalances. Okay, so essentially your potassium is going to be up, your phosphorus is going to go up, your uric acid is going to go up, and then your calcium is going to be low. Because if your phosphorus is high, your body compensates by pulling calcium out of your bone. Okay, but essentially, just think high phosphorus, uric acid, and potassium, and then low calcium. You're going to run into metabolic acidosis. And this is, we don't have to worry about this. Your textbook is correct. Okay. So how you can remember this. PEP is up. All right? PEP is up. This is something that people tell me they use all the time. When they interview for oncology jobs, they talk about Pep is Up. And then the other way you can remember if you're sitting there taking NCLEX and you can't remember if it's supposed to be high potassium or low potassium, this is my mother-in-law. Her name is Kay. And I say she's hyper. She's actually a really nice lady, and I love her dearly. And she knows she comes to lecture with me, but I've never told her why. But if you can just think, hyper K, it'll help you remember hyperkalemia. Okay? All right. I have great in-laws. I'm very blessed. And then there's CeeLo, to help you remember calcium's low. So Pep is Up and CeeLo. Okay? All right? Okay? So hopefully that'll stick with you forever. Okay. So what do we do? Basically, we want to hydrate, hydrate, hydrate. And actually, instead of reading this slide, I'm going to tell you a really embarrassing story. And I can't believe I tell this story because it's so embarrassing, but it's all true. But I tell this story because it explains what you do with tumor lysis. So when I took my boards, you had to wait like 2 or 3 months to get your results back, and I was in the middle of my internship, and so I got my results back, and I couldn't wait to go back to work the next day and tell everyone that I had passed. So I showed up, and I walk into the conference room, and there's this long conference table, and at the far end is the charge nurse, Cheryl, who was making assignments, then there were a couple other nurses. And I walked in, I just said, I passed. And Cheryl, she looks up, and she's kind of deer in the headlights, and she's like, oh, that's awesome, because now you count on staffing, and we are so short-staffed today. And I was like, what? And I was thinking, that's it? That's all I get? And she said, oh, and congratulations. And I said, oh, congratulations. So I'm like, okay, that was my welcome. So we were really short-staffed. I had 9 patients that day, and and a lot of them were on triple antibiotics. It was just crazy. And the thing is, when you're a new grad, all you want to do is prove that the state board didn't make a mistake by giving you a license, and that the people who hired you didn't make a mistake. You know, you just put on your big girl panties and you just do the best you can, right? So off I go, and it was one of those days, I was on the verge of tears all day. It was just such a hard, hard day. And just when I thought I couldn't take any more, Cheryl comes up to me, is at the med cart. She says, Jen, I'm so sorry, but I need to give you an admission. Everyone else has had one already. So it's a 5-year-old. She's 5-year-old with leukemia. She's coming in for her first round of chemo. Y'all, I knew nothing about cancer. I think I was absent the day we learned about cancer because I knew nothing. All right. And looking back, I think Cheryl must have been out of her mind for giving me this kid. She said, just make sure you follow the orders exactly. And I looked at her, I'm like, okay, just do my best not to cry. And I'm like, okay, I can do that. I can follow the orders exactly. So first thing I had to do after admitting her is hang this IV fluid. And so it was a very complex bag of IV fluid. And so I remember holding it next to the orders and going through everything. I'm like, yeah, it was right. So I go to hang this bag of IV fluid. And I'm hanging it, and the mom says, what's in her, IV bag? And I don't know why I said this. I'm so embarrassed. Can't believe I tell people this. But I said, glucose and nutrients. And Mom says, glucose and nutrients? Mom is a nurse. Just my luck. And she stands up, marches over to that bag, and whips it around. And she says, glucose and nutrients? This is bicarb. Why is she getting bicarb? And I had no idea. And you just say, I don't know, I was absent that day. And I said, I'm not sure. She said, well, can you go find out? Oh, my goodness. I was furious. Who did she think she was telling me to look it up? A, she wasn't my instructor. B, I had graduated. C, I had a license and didn't need to look it up anymore. I was so angry, and I was so far behind. And I was behind because they got admitted. And I was truly mad. I'm like, I don't have time to look it up, but I told her I would. I didn't really have a choice. So I looked it up, and I went to the little med cart in the hall, and I opened up the book, and I read that before induction chemo, you want to prime the kidneys with large amounts of bicarb so that the urine is alkalinized, and you want to prime those kidneys and those renal tubules with bicarb, okay? Because when the cells lyse open and uric acid is released, right, in an acidic environment, it's going to crystallize. In an alkaline environment, it's going to neutralize that uric acid, and it'll just kind of bounce right through those wide open tubules that you've primed with bicarb. And I remember thinking, oh, that's so cool. Like, there's a reason. You know, there's this IV fluid. So I go back and I told her. And she's like, okay, good. And then the next thing I had to give her was allopurinol. And she says, why is she getting that? And I'll never forget this moment. It's like your life is flashing by. And you're like, okay, I remember when I was studying for NCLEX, or boards, we called them back then. You give allopurinol for gout, but she's 5. So that's probably not why she's getting this. And I'm sitting there thinking, I'll be right back. So I went and looked it up. Allopurinol binds with uric acid, so it forms this nice little bouncy ball that bounces through the renal tubules that you've just primed wide open. Yeah, so I went back and told her. She's like, good. So then the next thing I had to give was prednisone. And I'm like, oh, well, I know about prednisone. You get that for inflammation. Well, you get it for about 100 different things. But, you know, I was prepared. Anyone know why we give prednisone for leukemia? It kills white blood cells. It's a frontline agent. So I learned that, too. I learned a lot that day. But anyway, it was one of those days where I was there until 9:30 at night sharding. And it was such a hard day. And I was truly angry at that mom because with each question and each thing that I had to look up, I was getting further and further behind, and it was all her fault. And, it was a blow to the ego, too. And I'm thinking, here it was, 9:30 at night. I saved her charting for last, and I was going through her chart, and I had read that the day before she had gone to the pediatrician's office. They did a CBC that had a high index of suspicion for leukemia. She got a call last night from her pediatrician saying, you need to go to the Hemont Clinic first thing in the morning, where she was diagnosed with leukemia that morning through the bone marrow biopsy and a spinal tap, and then was admitted to our unit for her first round of chemo, where it was obvious within minutes her nurse had no idea what she was doing. And so when I was reading this, all that anger immediately turned to shame, and I was like, oh my gosh, look at what they've been through. And her husband was out of town, so she was there by herself. And I had this epiphany that it's not about me and my incompetence. Yes, we have to own our incompetence, but we really can't be angry at that mom. I'm so grateful I had this epiphany that it's not about me and my incompetence. It is about that little girl and that mom in that room. And so the shame just came over me, and I put my tail between my legs, and I went into the room, and it was dark. Julie was asleep, and Mom was sitting in a chair, and I pulled up a chair, and I said, I was going through your chart, and was reading about what you've been through in the last couple of days, and I'm just so sorry that you have to be here, and I wish you the very best on this journey. And, she said thank you, and I said, I realized you could have thrown me out of the room and asked for another nurse, but I want to thank you for giving me a chance. And Mom was great. She said, well, I thought about it. Like, yeah, I'm sure she thought about it multiple times. And she said, but do you want to know why I didn't? And I was like, no. I'm like, no, can you just not talk about me? Like, no, I didn't want to know, and I didn't want to talk about me, but I kind of sucked it up, and I said, didn't really have a choice, but I'm like, yeah, sure. She said, well, I love that you're willing. She said, I love the way you interacted with Julie, and you were willing to learn, and you learned a lot today, didn't you? And I said, yeah, I did. And that's when I told her that I got my license yesterday. And she was, she said, the third reason, she said, you learned a lot, and I can tell you're going to be a really good nurse. And those words stung so bad. I was going to be a good nurse. They just stung because I was a nurse. I had a license for one day. And so that's when I told her that I got my license yesterday, and she was stunned. And so anyway, we bonded through that. Sometimes you just kind of have to suck it up and go in and just say, look, it's not about me, it's about you, and I'm just so sorry. And there are nurses who go through their whole career without having that epiphany that it's not about them. I'm sure you've met some of them, right? But hopefully you can keep that perspective. I'm just so grateful that I had that epiphany on my first day with the license. So if you can learn from my mistakes. I tell you that because you're all going to have a day like that. And I hate to tell you, but being a new grad is hard, and we're just scratching the surface. Okay? So we're almost done with this, and we'll take a break. Okay, so I think I talked about all this. The only thing I didn't talk about, because they're at risk for electrolyte imbalances, you want them on a CR monitor because of their potassium. And essentially, if their potassium does get high, you're going to give them KX-Late or other binders to get rid of it. You're going to draw labs every 6 hours. You're going to draw electrolytes. You're going to do a CBC. You're going to be looking for how they're responding and treat them symptomatically. Okay. Any questions about tumor lysis? We don't give allopurinol as much as we do urate oxidase. Okay, that's actually a lot more effective. And with adults, we don't give bicarb anymore, but to kids we still do. So you're probably not going to see bicarb with adults, but you will with kids, especially if their urine is not as alkaline as we want it to be. Okay?
We give the bicarb and you watch the analysis with the issue with like too much bicarb. Does it make sense to give it if it changes the acid-base balance?
It's usually not a problem. They usually do fine. Yeah, because we're giving them so many other things too, just for the chemo. Okay? Remission. In order for someone to be in remission, either an adult or a kid, you can still have some blasts in the CSF, but it has to be less than 5. Okay? So what you do, you give them this first round of chemo. You're going to do another bone marrow biopsy. You're going to follow up with a lot of blood work, but if you have less than 5% blasts in your bone marrow after that first round of chemo, then you're considered to be in remission. If you're not in remission, then you go up to a higher risk protocol. All right, let's take a break, short break, and then we're going to fly through the rest. But this was the most complex part of the lecture. Okay? All right, I'm going to go ahead and get started. I want to read an admission note, okay, while people are coming in. Okay, so this patient is an 8.5-year-old white female. Is that good or bad? 8.5? It's good, but she's on the higher end, so not great. Okay, but yeah, she's within that 2 to 9 range. She was admitted in general good health except for a history of recurrent sinusitis, otitis, and nasal allergies, who presents with new onset leukemia. The patient is about 6 weeks ago started complaining to her parents of a frontal headache. This seemed to be worse during the late day. Otherwise, she's been playful and active until recently when she seems to be more fatigued, although still very active during the day and is going to swim practice. The patient was seen by her primary care physician and was treated empirically for possible sinusitis with a course of Omnicef and then more recently a course of Augmentin. This did not seem to have a resolution of the frontal headache, at which time she did undergo a CT scan of her sinuses, which was negative. She also had some low-grade fever, nothing above 101, but she feels less energetic and the evening looks washed out and has low-grade temperatures repeatedly. This is despite the 2 courses of antibiotics. Family has been giving ibuprofen at home along with some of her chronic meds. Recently saw the ENT in follow-up and was told to stop the antibiotics as there doesn't seem to be a clinical sinusitis. The mother just had a strong feeling that there was something that was more prominent going on. Always listen to your moms. Prominent going on, and requested from the pediatrician to do some more screening blood work. So yesterday she was sent to the lab for outpatient labs, which were notified to the on-call physician, which showed that she had a high white count over 300,000. So you can see, typical scenario, sinusitis, they treat her with antibiotics, nothing major, she's going to school, she went to swim practice. Okay, 300,000 with moderate anemia and thrombocytopenia. Thus generating the emergency referral to our office. Okay. So she had an enlarged spleen, and there was hepatomegaly, no other masses. So white count, that was the night before. When she went to the Hemont clinic, her white count was up to 388,000. Just between yesterday and today, it went up from 300,000 to 388,000. That's how rapidly out of control these little cells were multiplying. Hemoglobin was 8.7, which really isn't so bad, and her platelets were 69,000, which is kind of interesting. You would expect with a white count that high for hemoglobin and platelets to be much lower. She had 78% blasts, 1% SAGs, 19% lymphocytes. Okay. They did a bone marrow biopsy, and they did a spinal tap and put in a PICC line. So typical scenario. And what did they do? They treated her with the rasburicase for the uric acid prophylaxis. They gave her bicarb. We're checking her labs every 6 hours for phosphorus, uric acid, and electrolytes. Yeah, so this is very consistent. This is what we do. Now, what I wanted to show you. Did I start this? Okay. This was after 1 month of chemo. The patient before her white count. What was it before? 95,000. Her white count came down to 20,000. But here it's covered up by this, but her blasts went from 80% to 93%. White count went down, but her blast count went up. So did induction therapy work? No. Okay. So that's refractory chemo. Did I tell you this patient here, she had a primary tumor, like a solid tumor, and then this is leukemia that showed up several years after she was treated. So this would be what kind of malignancy? Secondary. Good job. Okay. You don't need to know about AML other than the fact that it's much poorer prognosis, much harder to treat. Okay? All right. Okay. Main difference between pediatric versus adult cancers. This is oversimplifying, and everything I've talked about is pretty much oversimplified. Every tumor is very specific and very different. But the way I explain this to people, adult tumors are usually carcinomas, which affect organs. They emerge out of epithelial tissue. So if you think of organs like liver, lung, colon, adults get cancers of the organ, okay? And carcinomas evolve out of epithelial tissue. Adenocarcinomas, they evolve out of cells that secrete either mucus or other fluids, so like colon cancers and adenocarcinoma. But basically, these tumors get their names from the kind of tissue they originate from. With kids, they usually get sarcomas, all right? And sarcomas evolve out of soft tissue, embryonic tissue. So again, they don't usually get cancer of the organs. The exception is like brain cancer. That'd be considered. But essentially, it evolves out of embryonic tissue. And so they get soft tissue tumors, either in the abdomen, the brain, the bone, or the blood dyscrasias, like leukemia or lymphoma. Okay? So that's just an oversimplified way. What is the difference between adult and pediatric cancers? Okay? Here are some statistics. Fortunately, only 2% of tumors are pediatric, but it's still too many. You can see leukemia, lymphoma, and brain tumors make up the large majority. Okay. All right. All right, this is Baby J. If any of you haven't seen a VP shunt, this is what they look like. It's a great picture, and I love this picture because he's actually wearing my son's hand-me-down, so every time I see this picture, yeah. So this is my best friend's baby. His name is Baby J, and his mom and I have been best friends since we were 10. We talk every day. And these are actually his aunt's hands. I wish it was a nurse's hand, but it's not. It's his Aunt Nancy's hand. But anyway, he was diagnosed with a brain tumor when he was 3 months old. And so I learned so much. I thought I knew a lot as an oncology clinical specialist, but when I went through this experience with him, I learned so much more. And one thing I love about this picture, he was just really so happy and he loved playing with hands. He had a pineoblastoma, and both his mom and his uncle had this eye condition when they were little where the eyes just kind of bounced around a lot. And so he had that as well. And so we just kind of assumed that was the same thing. I was living here, they were living in D.C. So they made an appointment with the ophthalmologist. Finally, they got in to see him. He was 3 months old. They took one look at him, and they sent him straight to the ER, where they did a bunch of CAT scans, and he was diagnosed with a pineoblastoma. Hyper K was visiting me at the time. It was a Tuesday before Thanksgiving, and I talked to her that morning, and she called and she said, "Hey, we're in the hospital at Fairfax, and we just got news that Jay has a brain tumor." And I was asking what kind, and she said pineoblastoma, and I knew at that moment that he wasn't going to make it, knowing what I knew. And before I could say anything, she said, "Jen, I don't want to know what his chances are. I just need to believe he's going to make it. Otherwise, I don't know how I'm going to get through each day." And I had never had anyone tell me that before. And so that was like the first lesson. We know that we don't take hope away, but I had never heard it verbalized that way. I just have to believe he's going to make it. Otherwise, I'm not going to make it through each day. Very important perspective. And I said, okay. I would go home to D.C. about once a month to stay with him when he was getting treatment. I just learned so much from that experience, just being on the other side. A couple things that I want to pass on to you from that experience is the power that we have as nurses. Every time I give this lecture, I ask Kathy, okay, what should I tell students today about your angel? And she said, make sure you tell them how important it is that you love our kids. She was so proud to be his mom. And she said the fact that the nurses fought over who got to take care of him just always made her feel so good. And it made her able to go home at night so that they could be with their daughter. I learned how controlling nurses can be. And I'm just passing this on to you that if you find yourself getting into a control battle with family members, just stop. Stop and listen. We're taught to advocate, but we advocate on a completely different level than parents do. But I'll never forget, he had just had a tumor resection, and he was in the ICU, and he had an order for morphine. And I was asking the nurse if he could get some, and she's like, oh, he's too little. He can't have that. And it was just really, really frustrating. I'm like, no, he's not. But here's one thing that really hit me when I was staying with him. When we get report, we run around and we try to figure out how we're going to get all these 500 things done in the next 12 hours, right? To those moms sitting in that room, we're bored out of our minds. We sit there and, we can't wait for the nurse to come in because then we have someone to watch. So I never realized how much we were watched. But, it's like the nurse walking, that's like the most exciting thing that's happened in the last hour. So they watch everything you do. But I never realized how much power nurses have as far as managing their care. And I know you aren't allowed to get verbal orders, but I want to pass this little tidbit on to you. When you have to get a verbal order, let's say I wanted to get pain for him. If I call and say, hey, Dr. So-and-so, can I get an order for Dilaudid for baby Jay? Well, the answer you're going to get is, well, let's start out with Tylenol, and if that doesn't work, call me back. Whereas if you can call and say, hey, baby Jay's in a lot of pain, mom says Dilaudid works really well, what do you think we should do? Voila, you get your Dilaudid order. So just know it's an art form. Fortunately, I was on it and learned that lesson pretty well. So I learned how to get verbal orders. So keep that in mind. But one thing that I really learned from his mom was the importance of loving their kids and how comforting that is to those kids. And fortunately, it's really easy to love these kids. It's really not that hard. But one thing that really struck me is that in all these years of nursing, I never understood when a child dies, how is it those parents are able to walk out of the hospital? Like I would just watch them leave and just think, how? How do you do that? And so I asked her one day, and she said, and I think her response just speaks volumes. Without even thinking, she said, well, we left him with Kathleen. And she loved him as much as we did, so it really wasn't that hard because we left him with Kathleen. And I just realized, wow, that statement was so revealing to me that we really do develop that bond that is a gift to those parents in ways that we don't even realize. So I've just learned a lot through that. She also wanted to pass on that cancer sucks, which I think we all know anyway. But yeah, there's so many things I learned from that experience. But yeah, it's really neat because she still remembers all the nurses and all the gifts that they have. They remember you. They remember all those little things that you do for them. You know, it's 2000, so it's been 15 years. And she still remembers the nurses' names and all the different gifts that they had. So that's pretty powerful. Okay. Brain tumors. Here's what I want you to know about brain tumors. I want you to know the triad. The most common triad presentation is headaches, early morning vomiting, and ataxia. Okay? That's the most common presentation. The early morning vomiting comes from changes in position, that sudden movement, as opposed to nausea. They don't vomit because it's that change in pressure with position changes. The sad thing about brain tumors is we're getting a lot more sophisticated with our treatments, but we're not making progress in survival rate, which is really, really frustrating. When you look at the NCLEX books, these are the main things that I want you to know. Okay? This triad is really important for you to know. But the other thing that we see with brain tumors is a loss of developmental milestones. And that's what makes brain tumors so hard. Most kids are diagnosed around, young school age. That's the most common. And so you have these kids who, are running around, jumping, and then as their tumor grows, you'll see those developmental milestones decreasing. The other thing I wanted to, just going back to Kathy, one thing she said she knew that, from living with me, that I would go in to see my patients when they're dying all the time. But she said when people did that for Jay, people came in for a couple days to spend, that time with them, physicians and nurses, and they would come in their jeans and sweats. And she said, even though I know they do that for people, it's part of just what you do, she said she felt like they were the only ones they'd ever done that for. And she said it was so comforting that they did that for her. So, again, that culture is really, really important. And I'm just, I'm proud to be part of a culture that we do that for our kids. Okay, so back to this. You've got supratentorial and infratentorial tumors, which you'll see in the NCLEX books. Don't worry too much about that except for position changes. I don't want you to get caught up in the minutia with that. But what you do need to know, going down here, depending on where their tumor is, the post-op positioning is really important. So post-op, if they have an infratentorial incision, you want to lay them flat and on the side with the operative site up here, not laying on the operative site. And if they have a supratentorial incision, you want to have them flat but elevated 30 degrees. Okay, so that's an important NCLEX point. Also, if you have colorless drainage from the surgical site, that's a medical emergency. You need to call someone immediately. Okay, this is not a wait and see thing. You need to call if you notice drainage, colorless drainage, post-op. You want to look for sluggish, dilated, unequal pupils. Again, that's a medical emergency. These are the main things right here where you want to call. Often, depending on where the tumor is, you can have a problem with thermoregulation. So sometimes they'll get either hyper or hypothermic. So you need to watch them closely for that. Okay. In the PowerPoint, I left the links on the student one. If you want to watch any of these videos, you can just click on them on your computer. Okay. Neuroblastoma we already talked about. Here's what I want you to know about neuroblastoma. Aside from that, think of it as ovarian cancer, right? They come in with these big bellies. Angiogenesis. Prognosis is not that great. It's because it's usually metastatic at diagnosis. It's a very difficult tumor to treat, but we are making progress. The survival rate is going up, but you can see it's really not that great. Okay. Here's what I want you to know about stage 4S neuroblastoma. This is like the silver lining with neuroblastoma. Opposite from leukemia, if you're diagnosed with 4S neuroblastoma as an infant, excellent prognosis. The S, even though stage 4 sounds horrible, the S stands for spontaneous regression, and those babies do fantastic. Okay? Sometimes we don't even have to give them chemo. They will just spontaneously regress. I already talked about it. It's originally in the adrenal glands most of the time, but it can also occur anywhere upon the sympathetic nervous chain. And depending on the location, you can end up with these raccoon eyes. But this is what they look like. Okay? Good news is, look, she's a neonate. She's going to be fine. All right? Good prognosis. Even though it looks horrible, that tumor can go away by itself pretty easily. You can see this is all tumor mass right here. This is a portocath. And you can see how a neuroblastoma is very unforgiving. It just pushes and displaces those organs. It'll just grow everywhere. There's no free space in this abdomen at all. It's just crowding everything out. It's a pretty aggressive, nasty tumor. Okay. We're making a lot of progress with immunotherapy. We're doing some pretty exciting things with the neuroblastoma. Okay. I'm going to show you this real quick. Oh.
Isn't it beautiful?
So these are twins with stage 4S neuroblastoma. I just saw a video of them. They're like 6 years old now. They're so cute. They're so cute. Okay. So you can see how tight that abdomen is. Okay. And then okay. I don't know how well you could see it up there, but on my screen you can see pretty well. You can see that blue cheese vasculature that's feeding that tumor right under the skin. This is what they look like. Good news is they're doing great. They're in like first grade, okay? So that's the difference between 4S neuroblastoma and your regular neuroblastoma, which is prognosis not as good, okay? So I want you to know the difference between 4S and regular neuroblastoma, okay? All right, bone tumors. Okay. Basically, you have osteosarcoma and you've got Ewing sarcoma, and they present in different places. Osteosarcoma is more common, and it usually occurs in the growth plates. The most common place is usually either above or below the knee in the growth plates at the tibia or the femur, but it can occur anywhere in the long bones in the growth plates. So the most common place is the leg, followed by the arm. Okay? As I mentioned, it happens in the growth plate. It most often presents after a growth spurt or if you have a fracture in the growth plate. These kids are usually tall. They're basketball players, right? They just have this rapid period of growth, and you just have that haywire cell division going on. Okay? So this is very cool. We used to automatically do amputations because there's a high risk of it metastasizing to the lungs. We've learned, you think of body image being a problem and you don't want teenagers to lose that mobility, so there's this big movement to do limb salvaging procedure. Instead of just amputating, we're going to shrink that tumor with chemo and then debulk the tumor so that we can salvage that limb. What we've learned is that when you do that, you end up with more complications, and these kids often will end up on crutches because you've got unequal limb length. It's just hard to get around on crutches, lots of complications. And most people learn with all the advanced technology with prostheses, they much prefer to have the prosthesis and have the amputation. Okay, so you can see in the growth plate at the distal end of long bones. Okay, this is a very cool video. It looks like sci-fi, but we really do this. And this started way back in, like before World War II.
With a rotationplasty, part of the leg, usually including the knee, is removed. The healthy lower part of the leg is rotated so the foot is facing backwards and attached to the remaining leg or thigh. The ankle joint then functions like a knee joint. The nerves in the foot continue to provide information to the brain to help with balance. The blood vessels also remain intact. This operation is typically performed on children between the ages of 5 and 12. The goal is for the repositioned ankle to be at the same level as the opposite knee when the child is fully grown. Sometimes an additional procedure is required to achieve this goal.
I was only in third grade, and it's a big deal for third graders to understand. And so they brought someone and they showed a video and they explained to them that it would look a little different, but that I was still the same person I had always been. And for me, I didn't even think about the fact that it looked different. I just got right back into my normal life, and as soon as I accepted it, everyone around me accepted it too.
The muscles in the ankle joint must be gradually stretched through exercise and physical therapy before work on a prosthesis can begin. The prosthesis fits over the foot and extends up the thigh. The prosthesis is hinged at the repositioned ankle, which now acts like a knee. A person with a rotationplasty is able to move the prosthesis much more easily and control it much better than a person with a typical above-the-knee amputation. It's possible to bear weight directly on the leg in some circumstances.
Having rotationplasty has allowed me to do anything that I would like to do. I'm able to ride bike and rollerblade, play soccer, go hiking, go fishing, climb mountains, anything that anyone can imagine I'm able to do.
Sometimes the bones don't fuse properly after a rotationplasty, especially if chemotherapy is given after surgery. Typically, another surgical procedure can be done to overcome this. An individual's medical condition may or may not make a rotationplasty an appropriate option. Discuss your options with your healthcare team.
I am thrilled to have a rotationplasty. I count it as one of the greatest blessings in my entire life.
Awesome. All right. See, you get to work with people like that. It's just the best specialty ever. All right. Okay, Ewing sarcoma is the other kind of bone tumor that we see, and this occurs more in the shaft of long bones. It can occur...
Rotationplasty is unusual.
Sorry.
And basically the concept is that if you have a tumor...
Let's see. Uh-oh. We're almost to the end of this. Okay, so Ewing's is going to happen in the shaft of long bones. The most common place is actually the pelvis, right? But it can happen in the ribs, the skull. You don't need to memorize this slide. Just know the difference between Ewing's and osteo, in that it's either in the growth plate with osteo or in the shaft of long bones with Ewing's, okay? Moving on to Wilms tumor. Got it? This is what you need to know about Wilms tumor. Wilms tumor occurs on the kidney. It's a pretty common tumor. Prognosis is actually really good, but this is the main NCLEX point you need to know about that. Neuroblastoma, they actually present the same. They come with this big abdomen. Right? Neuroblastoma is very aggressive. It wraps around organs. Wilms tumor has a nice capsule around it, right? So it's this gelatinous capsule, and if you press on that tumor, that capsule can burst open, and then you can cause that tumor to break open. That's why you don't palpate the abdomen. Okay? It usually occurs on one side, but it can occur on both. Because it's on the kidney, you can have changes in blood pressure and kidney function. But generally, neuroblastoma crosses the midline. It can be on both sides, whereas Wilms usually occurs on one side only. So that's another thing we look for when we're trying to determine if a kiddo has Wilms versus neuroblastoma, because they both happen around the school age period and they look similar. Okay? All right. There's a nice encapsulated Wilms tumor. So you can see it's pretty easy to resect. Okay, so for the test, this stuff is important. There will be questions about calculating your ANC. Your absolute neutrophil count is a calculation that tells you how effective your body is at fighting infection. So you can have a white count of 388,000 like she had, but you have no infection fighting ability. Okay? So your ANC looks at your white count and combined with your presence of neutrophils, which are your effective infection fighting cells. Okay. So in this case, what you would do, you multiply 10.5, and this is an abbreviated white count. When you're calculating an ANC, you want to make it your actual true white count, which is 10,500. And here you can add up your segs and bands. Okay? So you'd have 92 segs and bands combined, right? And you're going to multiply the 10,500 times 0.92, because your diff is your percentage of cells. So let's see. There's your formula. So in this case, let's see. If you have a white count of 12, you're going to convert it to 12,000, and you're going to add your segs and bands together, and you're going to get a decimal point of 0.55, and you multiply it out, you get this. Where this gets tricky is when you have single-digit numbers. So if you have, let's say you have 4 bands, it's not 0.4, it's 0.04. So when you have your single digits, make sure you're careful where your decimal point is. Okay? So you have a white count of 4,000, you're going to add your segs and bands together. If you have 4 bands and you change that to 0.4 instead of 0.04, it's going to totally mess up your calculation. So this is pretty straightforward. Here's some examples you can follow. If you have questions about this, let me know, but it's pretty straightforward. These PD NCLEX points you need to know, right? Fair game. When you give someone chemo, you're going to wipe out their fast-growing cells. Your white cells are fast-growing cells, so you worry about neutropenia when you give people chemo. Usually 7 to 10, 14 days, that's when they're at highest risk for being neutropenic. All right. Did you learn about neutropenic precautions before? They're pretty straightforward. But one thing that you want to emphasize, you'll see in the NCLEX books all the time, someone sends flowers to the unit, you have to send them back. Basically, fresh fruits, fresh flowers, they are vectors for infection, so you don't want to expose your patients to that. If you are OCD, oncology is a good place for you. Basically, it just takes one little germ to kill a kid, right, or an adult for that matter, so you really, really have to be meticulous. All right, this is really, really important. If someone, if a kid comes in with fever and neutropenia, you ideally want to get your blood cultures started before you start them on antibiotics. There are emergencies where maybe they don't have a central line, you can't get a culture real quick. So if you have to make a choice between doing a blood culture, before you give antibiotics and getting it treated like you just can't get a peripheral stick, go ahead and give your antibiotics first. Okay. This is really, really important. If you have someone who calls and says, hey, my kid has a fever, and they're at risk for neutropenia because they got chemo like a week ago, you don't want to tell them, take some Tylenol and see how it goes. You want to bring them in and do a sepsis workup, okay? Because if you give them Tylenol and they are neutropenic, an infection can take over their body within a few hours and they will be dead, okay? You need to bring them in and treat them quickly. Okay, do not give them Tylenol. You're going to bring them in, you're going to do, blood cultures, you're going to do a white count. You know that they're going to be neutropenic. The most important thing is that you get your blood cultures done and you get them started on antibiotics as soon as possible. Okay? So, flossing. If they're neutropenic, flossing, it's such a vascular tissue, it's a portal of entry. So if you have bleeding from flossing, you can have bacteria that easily gets into the bloodstream. Okay, so if they're neutropenic, no flossing. These kids, like I said, are at risk for going into septic shock. I've seen so much septic shock in my career. You have to be on it. You have to have great assessment skills. No live vaccines. What are your 3 live vaccines that you need to know? This is important. MMR, varicella, and flu mist. These kids can get flu shots, but not flu mist. Okay? That's important. If they get exposed to chickenpox can kill these kids. You need to bring them in immediately and give them Vizig, which is an immune globulin specific to the varicella virus. People who are neutropenic, not just with cancer but other reasons, often they'll be on Bactrim prophylaxis for pneumocystis carinii pneumonia. Okay, so they'll be on that 3 days a week. Okay. Bleeding precautions. This is all pretty much common sense. People at Scottish Rite laugh at me because I have never given an enema, right? Oncology nurse, I just never have. I've been very lucky. I've had some close calls with non-oncology patients in clinical, but never done that. So we don't go near the rectum. The rectum is very vascular, right? So with a rectal temperature, a suppository, or enema, essentially if you have little micro tears, right? And those little micro tears or fissures are another portal of entry, and you can get E. coli sepsis in a heartbeat. So you just don't go near the rectum, okay? And again, you want to avoid constipation because that straining can cause those micro tears and fissures as well. This is important. We have them get a dental consult before they start chemo, because once they start chemo, again, portal of entry. You don't want any sharp instruments that can cause them to bleed out if they don't have platelets. Okay? And then the rest is pretty simple. You need to know with mucositis, it can occur anywhere along the GI tract. We think of it as mouth sores, but it can occur anywhere. You can have sores on the rectum, down the esophagus, and these kids are super, super sick. If you've seen, we call it pizza mouth. Basically, you know how one little canker sore hurts, that their whole mouth is like that. And again, they're at such a high risk for infection. Your mouth is a great portal of entry. These kids often will end up on Dilaudid drips because it's just extremely painful. The reason that meticulous mouth care is so important with mucositis is so that they don't end up with secondary infections. Again, if you've got lots of open mouth sores, it's very easy for bacteria to get in there. An important NCLEX point, you want to make sure they rinse their mouth frequently. You'll see using a soft toothbrush a lot, but really the most important thing you can do is do frequent mouth rinses so they don't get little food particles in their mouth that's going to cause infection. Again, I don't want to read all these, but those are pretty much the key points. All right. Okay, these you don't really need to, well, actually you do need to know. For radiation, you want to look for skin. Basically, when you do radiation, your side effects may be site-specific. All right, with chemo, they give exposure to the whole body. With radiation, it's basically specific to the site that's irradiated. So you want to do meticulous skin care. They will get tattooed at the start of radiation so that they know where to shoot those beams. You do not want to wash those off, okay? And you want to avoid lotions, okay, because that can cause burns. Okay. The effects of radiation are more cumulative, right? Fatigue is a big problem with those kids. And then long-term effects you don't need to know. I just list them so you realize that when we give these kids these treatments, it has long-term implications. You don't need to know them for the test. Okay. All right, we're going to move on to the next lecture, and we will get through this quickly. All right, any questions on that? Just when you look at those study questions that I posted, make sure you know all those key points for the NCLEX. Those are really, really important. Also, if you have questions, I love questions. I love when people have questions. It helps me know where I need to explain things a little bit better next semester. And then it's just really satisfying to kind of talk you through if there's some things that you're confused about. I can really help you. I want you to do well on the tests, and I really want you to understand this. Okay? All right. Hematology. Here's like the basis. Just think fetal hemoglobin is good. Fetal hemoglobin is produced throughout pregnancy. But it's that last trimester where you get the most kick or the most bump of that fetal hemoglobin development, especially that last month. So preemies miss out on that last bump of fetal hemoglobin development. When babies are born in term, they have this beautiful store of fetal hemoglobin, which is very protective. It's good, right? What happens is that when that fetal hemoglobin store dies off, it gets replaced with it gets replaced with hemoglobin A, all right, which is your adult hemoglobin, all right? Generally, the supply lasts for 4 to 6 months, so you want to be proactive and not wait for that supply to deplete, okay? You need iron to maintain that store of hemoglobin, okay? We'll come back to that when I talk about iron deficiency anemia, but just so you know, when you've got premature infants, they're going to be born with a low supply of fetal hemoglobin. So they're going to deplete that supply much faster. They're at high risk for anemia. Also, multiples. You've got triplets. Those are 3 babies fighting for that store of fetal hemoglobin. So they're at high risk. You need to be proactive. Excuse me. All right. I'm going to talk about sickle cell. You have a VSIM on sickle cell, and it's for a high acuity. It's for splenic sequestration, so I'm not going to spend a whole lot of time on that. But sickle cell is something you need to know for NCLEX. I know you've already had it in adult 1, right? But I'm going to point out some of the things that are specific to pediatrics. Okay. Do I need to go over like the basics of this? Do you all remember this from adult? Okay. You do need to know the genetic composition is autosomal recessive. So both parents have to be carriers, right? If both parents are carriers, you've got a 25% chance of having the disease. You've got a 50% chance of being a carrier and 25% chance of not being affected. So just like with cystic fibrosis, you need to know what that means. Okay? So with sickle cell, essentially when that fetal hemoglobin dies off, instead of it getting replaced with hemoglobin A, it gets replaced with the hemoglobin S, which under certain conditions is going to sickle, and it's going to cause clumping. With kids, you've got teeny tiny blood vessels, all right? So when you have a sickle cell crisis and you have that clumping of sickled cells, you can do a lot more damage more quickly because those blood vessels are so tiny. Okay? All right. A number of complications can go wrong, and it's basically a perfect storm. Under certain conditions, if you're poorly oxygenated, if you're dehydrated, if you're sick, essentially that's going to facilitate that sickling dynamic. But also, compounding that is that you've got a lifespan of 10 to 20 days as opposed to 120. Okay? All right. Cute little picture. So here are a number of things that can go wrong. What's specific to kids is that if children are going to die from sickle cell, most of the time it's going to be from infection. Okay? So it's really important for these kids to be on prophylactic antibiotics daily. And immunizations are very, very important for these kids. Did you have a question?
Yeah, I was wondering if sickle cell at all affects your white blood cell count. I had a sickle cell patient the other day, and she had a really high white blood cell, but she didn't have like a history of infection.
You hadn't been treating with antibiotics? Usually the problem is not with the white count. Sometimes you can have an aplastic crisis where you end up with pancytopenia, but it's pretty rare. Usually the defect is with just hemoglobin. Okay. But yeah, about the mortality rate is pretty high with the bacterial infection, so they need to be on daily prophylactic antibiotics. And then there are 3 immunizations that are really important. I think I have a slide on that. Okay. So if you think important, I for influenza and Hib, M for meningococcal, and P for pneumococcal. Okay? All right. Yeah. Okay. So ischemic or vaso-occlusive crisis, that's the same as an adult. Essentially, this is where you've got sickling, usually in the periphery someplace, so a lot of times it'll be in the arms and legs, but it can happen in the abdomen. It can happen anywhere. What's really unique to kids is dactylitis, which you've got hands and feet that are affected by the sickle cell. Very painful hands and feet. That's called dactylitis. All right. Here's your aplastic crisis where your bone marrow just sort of shuts down. Chest syndrome we see with kids. You need to know chest syndrome. Essentially, it's a life-threatening emergency. It looks like pneumonia. If you don't treat it, they can die. Stroke. Stroke is actually pretty common in kids, and it's because those blood vessels are so small. Okay? So if you think of all those little vessels in their head, they're tiny. These can go unnoticed when they're little, and a lot of times you don't even realize they're having them unless you do a CAT scan and you can see these little infarcts. Okay? Kids are pretty resilient, but you can see some deficits. If they do have one stroke, there's a very high likelihood that they're going to continue having them. And so what we do with those kids is we'll give either chronic blood transfusions, which helps with that, or we can do plasmapheresis monthly, which pulls off those sickle cells. And we can replace them with healthy red blood cells. Just like adults, they're at risk for renal disease and jaundice, just because you have anytime you have rapid hemolysis, hemolytic process, you're going to have an increase in bilirubin, so it's not unusual for these kids to be jaundiced. Josie, was your kid jaundiced, or your? No? Okay. All right, talked about that. All right, there's your hand-foot syndrome. Knowing your triggers is really, really important. Your classic example of something that will throw a kid into crisis is if it's a really, really hot day and they jump into a cold pool. You've got extreme temperature changes. Okay? You'll see questions on NCLEX like, you don't want them to go camping in the mountains in high altitude. Okay? You want to make sure that if they're at Six Flags, they're hydrated. Dehydration is a real common stressor. Illness, anytime they get sick, it can trigger a crisis anytime they're stressed. So knowing those triggers is important. The most important intervention is going to be hydration. It's so frustrating because the NCLEX books have not caught up with this. Most of the time, these NCLEX books will say hydration and oxygenation are the most important interventions. Okay. Here's the problem with giving them oxygen when they don't need it. If they are symptomatic, if their SATs are below 92%, then yes, you want to treat them symptomatically. But if they're satting fine and they're not symptomatic, giving them oxygen can actually interfere with hematopoiesis, okay, because it's telling your body you don't need to produce more, okay? It doesn't reverse sickling, but it can prevent sickling. So if they are symptomatic, putting some oxygen on them is okay if it prevents further sickling, but you're not going to reverse sickling with oxygen. The most important thing you can do for these kids is hemodilute them. Hydrate, hydrate, hydrate. You want to open up those blood vessels. You want them to position themselves comfortably, but if they're in the fetal position, it's going to be hard to get that blood flowing the way it should. So if you can straighten them out as much as possible, do that. Okay? Anything else? A lot of times these kids can be managed at home with Tylenol with codeine, and it's such a stigma that, people refer to people in pain crisis as drug seekers, but this is real pain. You have to take this pain seriously. Okay? It's very debilitating. Okay, I already talked about stroke. Aplastic crisis is when you've got, that's where you're going to have the pancytopenia, usually after parvovirus exposure, or glue sniffing can trigger this as well. But essentially, the only way you're really going to be able to treat them is with the transfusion. Sometimes if they have a chronic problem with this, they will do a bone marrow transplant. We're actually seeing a much better effect with bone marrow transplants. It's not quite as investigational or controversial as it used to be. Okay. Acute chest syndrome, essentially, just think of it as life-threatening pneumonia that you got to treat quickly. All right, this is not what your chest is supposed to look like. Your lungs are supposed to be full of air, which would be all black. This is what chest syndrome looks like. Okay. Spleen note sequestration is what the VSIM is about, so I'm not going to talk too much about this. But essentially, you think of this as shock. Okay. The spleen in sickle cell plays a very important role. It plays an important role in processing your red blood cells. In sickle cell and a lot of these other blood dyscrasias, you have an overprocessing of the red blood cells in the spleen. And if it goes haywire and starts overprocessing, a number of things can happen. Okay. One thing is your spleen just stops working. It's called functional asplenia. Is that right? Am I saying that right? Functional asplenia. So basically, your spleen is still there, but it's not working. Okay. So that's a result of overprocessing these red blood cells. With spleen note sequestration, what happens is you have rapid pooling of blood into the spleen. And essentially, think of it as shock. All right? Usually these kids, their abdomens are enlarged. You have all that pooling of blood in the abdomen as opposed to in the periphery, so they're going to look like shock. And you treat them like shock, and then you get them to the OR after you've managed the shock, and you take the spleen out. Now, anytime you take a spleen out, it's a big deal. Those kids or adults need to be on antibiotics for life. I had a student in assessment several years ago that I talked about in pinning one year. But essentially, she had hereditary spherocytosis. And essentially, that's where your red blood cells, instead of being disc-shaped, they're round. And the reason that that's a problem is that your surface area, compared to the volume of the cell, is impacted. I don't want to go too much into it, you don't really need to know this, but essentially they treated this by doing a splenectomy on her. She was 45 when she was in clinical with me, and we were in simulation on Friday. And then Friday night she wasn't feeling really well, and then essentially she called her daughter. She ended up going into septic shock because she didn't have a spleen. She ended up on life support on Saturday. She coded 3 times on Saturday, and then we went in to see her on Monday, and then they took her off life support on Tuesday. Again, these kids without spleens, it's life-threatening if they get an infection. They are at high risk for septic shock. Okay? Okay. Again, they're going to be on antibiotic therapy for life. Okay. All right, how do we treat sickle cell? A lot of it is symptom management. We treat them with crisis as needed. Hydroxyurea is actually a chemo drug, and what we learned sort of accidentally is that a side effect of hydroxyurea is the increased production of fetal hemoglobin. Okay? So we now use hydroxyurea as a drug to increase fetal hemoglobin production. Okay. Hold on, I just had a thought. What was it? I'm sorry, I can't remember. The VSIM talks about taking folic acid supplements. That's it's not proven to work. I'm actually kind of surprised they put that in the VSIM because we don't. Oh, I know what I want to talk. I want to talk about retic count. Sorry. A lot of times these kids, you'll see a high retic count. What does your retic count tell you? It's telling your body that in response to some sort of either hemolytic process or bleeding out process, your body is going to respond by turning those hepatopoietic stem cells into red blood cells, as opposed to leukemia, where if you're fighting an infection, your body just knows to produce white blood cells in response to an infection. In response to a bleeding or a hemolytic process, it's going to produce reticulocytes or immature red blood cells. Okay? So it's not unusual to see a high retic count in sickle cell because you have the rapid breakdown of red blood cells. So that's a pretty common lab that you're going to see. Okay, iron deficiency anemia. This is pretty straightforward. I have a picture of this little kiddo drinking milk because in the Hemont Clinic we see a lot of milk babies. Okay, one of the most common causes of iron deficiency anemia is either giving babies cow's milk before the age of 1 or giving too much milk after the age of 1. Okay, you'll see this in the hospital all the time. You'll see someone admitted for like pneumonia and you'll do a CBC and they're really anemic. You ask, what do you feed your kiddo? And you have all these moms who are so proud. Oh, my kid is a great milk drinker. He drinks 8 glasses of milk a day. Cow's milk can cause microscopic bleeding and is a poor source of iron. Okay, most people don't know that. It's important that as nurses that you know that. And if you have friends who are feeding their kids tons of milk, make sure you alert them to the dangers of that. But it's very, very common, and that's why we call them milk babies. Okay. This is a video you can watch that a couple of our students made. And actually, they're using this at Head Start. This video was created for Head Start by a couple of our students. And when kids, did anyone get some low hemoglobins when you went to Head Start? Yeah? The finger sticks, yeah. So when they're referred for that, then they watch this video. And it's really more about diet management, but it covers some of the key concepts. What you need to know for NCLEX is more about medical management, all those things you learned in pharm about iron administration, you need to know for iron deficiency anemia, like giving it with orange juice and yada, yada, yada. Remember all that? I'm not going to read these to you because it's very straightforward, but you do need to know those implications for giving iron. Okay, so when kids are anemic, a couple guidelines. You want to make sure that they are getting a source of iron prior to the age of 6 months. Usually by 4 months, we want them to have some either iron-fortified cereal, or if they're strictly breastfed, a lot of times we want them to be on supplements, iron supplements for prevention. Preemies who are strictly breastfed should be on an iron supplement. Okay. And then teenagers are high risk. They have a poor diet, typically, and then when they start their periods, they can also experience increased anemia. Symptoms for anemia are the same as kids as they are adults. These should all look familiar. Okay. How do we diagnose them? We've gotten to see in clinical a couple patients who have had anemia, and the CBC actually will tell us that the cells are microcytic and hyperchromic. In iron deficiency anemia, your cells are going to be small and colorless. Those are one things we look for. The CBC tells us so many things that you generally don't know to look for, but it's so fun when a patient comes in with anemia just trying to figure out what it is. And one of the first things we look at is, are the cells small and colorless? Okay. In like a vitamin B12 deficiency, your cells are actually going to be macrocytic. They're going to be big. So that's one thing that we look for. Okay. Your H&H and your serum iron concentration will be low. If you are deficient in iron, your total iron binding capacity is going to be high. Okay. All right. So what do we do? The best thing we can do is prevention, but if they are anemic, the first thing we're going to do is give oral supplementation. Okay. We don't mess around with diet if they're already deficient. We want to educate families about how they can increase the diet, but generally we'll go straight to medications. If usually we give them the iron supplement, and then we'll check them again in a month. If it doesn't go up, you worry about two things: non-compliance, and the way you're going to ask if they're compliant or not is ask them about the stools. If their stools are not green or black or that tarry appearance, then you worry either about non-compliance or malabsorption. Okay. If the iron supplements don't work, then you're going to look for other causes of the anemia. But most of the time, it's pretty easy to fix because those cells are hungry for the iron, and then your body responds pretty quickly. Okay. These, I'm not going to read them to you, but you should know them. These I just put as a guideline, but you don't need to know all these recommendations, but you do need to know these, okay? Iron-rich foods, these are important to know, because when I talk about thalassemia, these are the foods you want to avoid, okay? So these, if you have an iron-deficient kid, these are the things you want to encourage, but there are certain circumstances where you want a low-iron diet. Okay. Hemophilia. Have you learned about that in your other classes? Hemophilia is a deficiency in clotting factors, and there are many different kinds. The most common is a deficiency in factor VIII, which is your hemophilia A. Okay? In the hemophilia A, you have bleeding into the joints most commonly. Okay? It's a deficiency in your clotting cascade, not with platelets. Okay? So, it's hereditary. It's an X-linked recessive disorder, meaning that it's carried on the mom's side. Okay? So females can become carriers, but it affects boys. However, about a third of the time, it's just a spontaneous mutation. Okay? That's going to cause this. This is important to know. You have prolonged bleeding, and your PT is prolonged, but your platelets, your PT, and your H&H are usually normal. Okay? Most hemophilia, it's a factor VIII deficiency, but there is a factor IX deficiency of Christmas disease. It's named that after a physician. Okay? Just FYI. Okay, so what happens, and this is just a good chart that explains the genetics, okay? So with hemophilia, what happens is they're going to bleed out most of the time into the joints. Most of the kids that I've taken care of with hemophilia also have AIDS. When I worked at the National Cancer Institute, it was pediatric oncology and HIV, and this was in the late 80s, early 90s, and it was a really exciting time to be there. But most of the kids with hemophilia were infected because most of these kids are either on either prophylactic factor VIII, or during a bleed, you're going to give them an infusion of factor VIII just through a butterfly needle. Each vial of factor VIII has up to 100 donors, the plasma from up to 100 donors. Okay, so if you were a hemophiliac in the late 70s to early 80s, the odds of you getting infected were pretty high, just because you go through vials and vials and vials, and the fact you have 100 donors in each vial, most of those kids did end up with AIDS. So, I don't think I've ever taken care of a hemophiliac that didn't also have AIDS, so my perspective is a little bit different. But when those kids would bleed out on the floor, essentially, you administer first aid, and the mom would whip out the factor and the butterfly needle out of her purse and inject it into the vein while you're administering first aid. So, how do we treat it? Prophylactically with factor VIII infusions, and then during a bleed, we're going to give an extra dose of factor VIII. The good news is now we have recombinant technology so that we can manufacture this in the lab, so we're not exposing them to 100 donors anymore. Okay. I put the pictures here. Oops. To help alert you that this is where the bleeds occur in hemophilia. In von Willebrand's disease, it's also a form of hemophilia, but it's a deficiency of von Willebrand factor, and those bleeds occur either in the mucosa of the mouth or the nose. So anyways, hemophilia, think joints. So when you have these bleeds chronically into these joints, you're going to end up with joint damage. So what's really important to know about that is that not during a bleed, but in between bleeds, you want to make sure you're doing a lot of range of motion. Most of the kids I've taken care of were wheelchair bound because of these bleeds. But your management, you need to know. The magic number is 15 minutes. All right? You need to apply pressure for 15 minutes during an active bleed. Your typical, elevation, immobilization of the joint, the administration of ice, those are really important. Just don't get sickle cell confused with managing a hemophiliac bleed. Okay, with sickle cell, you want to think vasodilation. With hemophilia, vasoconstriction. Okay, you do not want to be doing range of motion during the bleed, right? But just when they're doing well, you want to make sure you do range of motion exercises with them. Because they're high risk for bleeding, again, nothing per rectum. All right. Sometimes just doing a blood pressure can cause a bleed, so we only do blood pressures if we need to. Avoiding the IM or sub-Q injections is important. And really, most of these kids will have a portacath, so if we do need to give it, it can be given through a butterfly needle into the arm, but most of the time we can just use the port. And no aspirin. Okay, let's see. Okay, so medical emergency is a head injury. You know, you hear about those skiing accidents where people hit the tree and they're fine, but then the next thing you know, they die from a bleed. Kids with hemophilia are at high risk for bleeding out from a head injury. So this is really important. If you end up as a school nurse or a neighbor, you have to be very, very cautious. Even if they're asymptomatic, if they hit their head, you send them to the ER immediately so they don't bleed out outside of the hospital. Helmet use is important when they're little. You'll see these little kids wearing helmets when they're learning to walk and stuff. And then non-contact sports are the best. I went on this trek in the wilderness a few years ago, and I had a kid with hemophilia, and it was so scary. He hung out with me the entire time, and every time he fell, you know, it's just a constant worry that, you know, anything can happen with them. Okay, von Willebrand's, also a kind of hemophilia. It's actually the most common kind of hemophilia. 1 in 100 people have this, but we just generally don't know that we do. So it could be someone in this room has it. Essentially, these kids are high risk for bleeding, so you want to make sure you give them their von Willebrand factor or DDAVP before they go to the dentist. You want to make sure you know how to manage a nosebleed. But essentially, von Willebrand factor plays a role in, you think of it, the glue that holds the platelets together. It's just an important factor that kind of gets overlooked a lot of times. Okay, this is autosomal dominant, so both males and females are affected by it. Okay. All right. So again, they're not as severe. It's actually considered much more mild, but you still have to be proactive. Treat them actively with factor if they're having a nosebleed or an oral bleed, and treat them before they go to the dentist. Okay. So DDAVP, we use that for a lot of things. I put this little trick to help you remember. Von Willebrand ends in a D, so just think DDAVP. Okay. Pretty straightforward. And I think this is the last thing I'm talking about, thalassemia. Thalassemia is a group of inherited blood disorders that affects hemoglobin. The one that you need to know about the most is Cooley's anemia, which is beta. It's actually a really fascinating disease to read about, but I don't want to crowd your minds. Just think Cooley's anemia is thalassemia B. You've got A chains and B chains. Cooley's anemia affects the beta chain. It most commonly affects Greeks and Mediterraneans. All right, autosomal recessive, again, same as sickle cell and cystic fibrosis, so you need to know that. These have a classic bronze appearance from the iron overload pigments. And the main problem with Cooley's anemia or beta thalassemia is that they need chronic blood transfusions. All right. Because they have that defective hemoglobin, they don't live 120 days, and they have a hard time replenishing their supplies. So effectively, these kids get treatment through blood transfusions once a month for life, which is kind of a pain. That in and of itself isn't as much of a problem as a complication from chronic blood transfusions, which is iron overload. He saw this really cool video, but it's not on the internet anymore, but it's really dramatic. The problem with iron overload is that it causes lots of organ damage, especially the heart. It can cause, severe cardiac damage. All right, so what do? Anyone who's on chronic blood transfusions, we need to give them either Exjade or Desferal. Desferal was a standard treatment for a long time, and the problem with Desferal, it binds to that iron and helps chelate or remove that iron and excrete it. It's given through a sub-Q needle overnight. So usually these kids, they will get that overnight for life, and it's fine until they become teenagers and they become non-compliant, right? They don't want to do this at night anymore. The nice thing is we now have the Exjade, which has been around for about 10 years. It's not as problematic, but we still use Desferal, via the pump in certain cases. So just think glucosamine, it's autosomal recessive, defective hemoglobin, chronic blood transfusions, iron overload, and why you need to do the chelation therapy. And here's my link to that video that doesn't work anymore. But these are all the complications that can happen related to the iron overload. Okay? And then these are the kids you want to avoid those iron-rich foods that I talked about earlier. Okay? Again, these kids will often have problems with the spleen. You have overprocessing of the red blood cells, so they'll end up with the splenectomy. In that case, they need to be on the long-term antibiotics. Okay. Aplastic anemia you don't really need to know about. Okay? And that's it. All right. If you guys have questions, please email me. I love questions. All right.